It is 3.
Can't see Sunita. Sunita was.
Yes.
Yeah.
Should I give a call, madam?
Yeah,
she is
just
there.
Sunita, are you with me? Sunita. She had logged in. Farhana, now your slides were in slideshow. Just now.
Yeah.
Yeah.
Okay, hopefully during my presentation it will be okay.
Yeah.
Okay.
Sunita madam is logged in, but I don't know, she's not.
Yeah, where is she? Sunita?
Ma'am is there actually. Ma'am is there.
Really, ma'am?
Hello.
Yeah, madam is
I
there.
am very much here. I was
Yes.
not able to unmute myself from the phone.
We
So
can-
I'm very much here.
Okay.
Okay, ma'am. Foxy, Dr. Sunita Tandurkar, Dr. Now the recording is started. Okay. Respected President Foxy, Dr. Sunita Tandurkar, Dr. Parag Biniwale, Chair ICOG, Dr. Ashok Kumar, Vice Chair ICOG, Dr. Suvarna Khadilkar, Secretary General Foxy, Dr. Sarita Bhalerao, Secretary ICOG, and Dr. Lakshmi Shrikhande, Convener, and my dear friends who have joined from all corners of the country. This is a ICOG Masterclass on Fibroids, and it's an extreme honor to welcome our President Madam, who has joined in spite of her so very tight schedule to give us few words of wisdom. Madam, your love for the Foxians and your love for God. So I will just take this opportunity to dedicate these few lines to you and all those who have joined. Within this webinar, a place of grace where love abounds in every space. May you find peace and hope anew as we welcome you all with hearts so true. Without any more ado, I will hand over to Madam for her presidential address. Dr. Sunita Tandurkar, President Foxy, nobody needs any introduction to her. Madam, all yours.
Thank you, Supriya. Thank you. And thank you for always setting the mood with the right shairi. Sometimes spontaneously, sometimes you give a little time to think over, but it's always great fun. Lakshmi, fantastic initiative here. Parag has chosen the right people at right places. Congratulations to our ICOG chairperson, Parag. What is very important is the fibroid. There is so much of a dilemma, medical line of treatment, surgical line of treatment, to whom to operate, how to operate, and when to operate. So many things we can discuss, and I think you people have chosen such a right faculty for everything, whatever said and done. From diagnosis, I think Sonal will be highlighting her way of diagnosing, proving that you don't need an MRI when you have an expert sonologist with you. So probably, this such a focused topic. When Parag, I really congratulate you. One topic and have a master class and educate and upgrade. I know there may be hundreds of master classes by now in 5 years on myoma, but every time we bring in different advances, experiences, because the science and technology is evolving, our experience is also evolving, our inclusion and exclusion criteria are changing. And that's why such master classes are so important. And thank you for having me always there in your all program. I know by default, but with love, you people get me. I have just finished a fantastic, my third Arogya Yoga Yatra destination to Orissa. In Puri, the way Dr. P.C. Mahapatra, Hara, Janmajaya, and the entire team has worked for last 2 days with 8 medical colleges and getting a VIP darshan at Jagannath. And now I'm by road reaching to UPCon. UPCon, of course, it's the most prestigious conference of UP. But tomorrow we are launching our very dear to everyone's heart project, that is Nirmal Banaras Abhiyan, where we are trying to make Banaras cervical cancer mukt. Of course, we want to do the entire Bharat, the cervical cancer Mukta Bharat, but somewhere we have to rope the seed. And there in Banaras, we are starting. So we are launching in a very big way tomorrow. I want all of you to bless us and be there mentally, physically, or emotionally. Get connected. Your blessings are very important for every activity of Foxy. Thank you so much. 73 people will be together blessing me. Will be a great thing.
Thank
Thank
thank you,
Thank
dear.
you so much for your kind words, ma'am. Your precious time that you have given us and your wisdom that you're carrying and bringing from all over India. It's indeed your blessings to this perfect mastermind class today. And thank you so much for your presence, ma'am. Thank you. I will request Dr. Lakshmi Shrikhande ma'am now, and she herself also does not need any more introduction. So I think the mastermind behind the masterclass of ICOG, she is the director of Shrikhande clinics in Nagpur, past chair ICOG, and always a very active member. Definitely, she well deserved her honoris causa FRCOG. And madam, this is now for you for your kind words.
Thank you, dear Prachi. Good afternoon, everyone. It is my absolute pleasure to welcome you all to this masterclass on fibroids, advances in diagnosis and management, organized under the aegis of ICOG. Fibroids are one of the most common gynecological conditions we encounter. Yet their diagnosis and management continue to evolve with new research, advanced imaging techniques, and innovative treatment options. I would like to extend my heartfelt gratitude to the ICOG chair, Dr. Parag Biniwale, and Secretary Dr. Sarita Bhalerao for their support in making this academic session possible. We have 3 international and 6 national speakers who will guide us through an evidence-based approach to fibroid diagnosis and treatment strategies. From understanding the Figo classification to choosing the right pharmacological or surgical intervention, this masterclass aims to equip us with the latest knowledge for better patient care. So I sincerely thank our esteemed speakers and chairpersons for their time and expertise. Special thanks to our session coordinators who will ensure smooth proceedings today. I would like to introduce all 3 of them to you. Please show their slides. Dr. Supriya, she is the national coordinator for our Foxy Adolescent Health Committee chairperson, and she is senior consultant practicing at Thane, Mumbai. Then we have Dr. Prachi Dikshit, who is assistant professor at AIMS, Nagpur, and she is very active member of our Nagpur OBGY Society. Then we have Dr. Nagina Naidu from Chandrapur, who is currently the treasurer of Chandrapur OBGY Society, and also she was the treasurer of the highly successful AMOX, that is our state AMOX conference. So I would like to thank you all for joining us to exchange ideas and enhance our clinical practice, because without audience, we cannot have any program which we can say that it's a successful program. So let us make this masterclass interactive and insightful.
Thank you, ma'am. Over
Thank
to you,
ma'am.
Nagina.
Thank you so much. At times, whenever I think of fibroid in my mind, I just think the lady must be saying, I am officially announcing that my uterus and I are breaking up. Because the stalwarts today we are having, we're definitely going to guide us in a proper way. And even at the end, the lady can say that, yeah, I had removed you from your from my body, but still I am hot. So on this note, I want to invite Parag Biniwale sir. Definitely sunlight showing sunflower, each other they are facing. He doesn't require any intro, definitely. Sir, the house is yours.
Thank you, Nagina. Good afternoon. I bring greetings from ICOG, and it's indeed a pleasure to address the audience today. with yet another episode of Masterclass. Thank you, Dr. Lakshmi Shrikhande, past chair of ICOG, for taking this initiative and roping in so many knowledgeable speakers who are going to deliberate on different aspects of fibroid and fibroid management. Special welcome to our SAFOG speakers, Dr. Farhana Diwan, Dr. S.K. Zinnat, and of course, Dr. Amla Khopkar, who's our own export to UAE, I should say. Today's deliberations are definitely going to be interesting when we have learned faculty like Dr. Sonal Pancha, who's one of the best in the country, to talk about the imaging modalities. Thank you, Sonal, for being here with us. I look forward to some interesting learning for all of us. My best wishes for the program. And thank you to all the coordinators who are so enthusiastic right from the beginning. Thank you very much. And let's
Thank
go
you,
ahead.
sir. Thank you so much.
Nilima, can we see Suvarna? Has Suvarna Fadilkar logged in?
No,
If she-
ma'am, I checked. I don't think she is
Okay,
logged
so
in.
Not yet. Not
yeah,
yet.
let's start with our
So
session.
we will immediately, yes. I'll take this opportunity to welcome Dr. Ashok Kumar, Dr. Dr. Suvarna and Dr. Sarita. And now we are, without much delay, we will start the scientific session. Can I request all the delegates to please mute their screens? All delegates can please mute themselves so that there is no disturbance during the classes, during the master class. There are few announcements for all the chairpersons, esteemed chairpersons that have joined in, that this is an academic exercise. So I request you to introduce the speaker in exactly 2 to 3 lines so that we can give more time to the deliberations. All the delegates can put their questions in the chat box. We have enough time for audience interaction also. So I will proceed now with the first session, and for that, let me invite the chairpersons for today. We have 3 extremely esteemed chairpersons for today. You can please, yes, Dr. Sulekha Pandey, ex-professor and head of the department, Institute of Medical Sciences, Banaras Hindu University, Varanasi, and ex-professor and head of UCMS, Nepal. Madam, welcome. We have Dr. Pushpa Jungare, honorary professor and head of department of PDMMC, Amravati, and past president, Amravati OBGYN Society. Welcome, madam. And we have Dr. Suman Sinha, chairperson, Foxy Vaginal Surgeries Committee 2024-27, and member of the GCPR committee, SAFOG, past president of Ranchi OBGYN Society, founder president of ISOPA Ranchi chapter. Welcome, madam. And it's a great pleasure to have invite our first speaker for today, Dr. Ritu Dargan. And I will request our chairpersons to please introduce Madam in 2 to 3 lines or maybe 4 lines. Madam, can Dr. Sulekha please do the honors?
I can hear you.
Yes,
Good,
ma'am.
good afternoon. Welcome to all the respectable dignitaries of Foxy, ICOG members of organizing committee, my co-chairpersons, speakers, delegates, and all the office bearers. Thank you all, first of all, for inviting me in this important webinar. My special thanks to dynamic Dr. Lakshmi Shrikhande, who very nicely organizing series of webinars. Now, we all are anxiously waiting to hear, to listen to the important topic, the various aspects of fibroid uterus by all the excellent speakers. So without wasting my time, I request Dr. Ritu to speak on her topic. Dr. Ritu is a senior consultant and HOD of New Era Mother and Child Hospital, Nagpur. He is the director of Integral Specialty Clinic, Kamla, Nagpur. So without going into without wasting any time, so Dr. Ritu, please, you can start your topic, and we all are anxiously waiting to listen. Thank you.
Thank you so much, ma'am. A very good afternoon to everybody. And thank you, Dr. Lakshmi, ma'am, for this opportunity. So I'll just start screen sharing. The slides visible?
Yeah. Yes.
Yeah. So
request all the speakers to please finish their presentation in 15 minutes. Thank you
yes,
so
ma'am.
much.
I've put the timer. I've put the timer.
Yes. Thank you.
So,
Thank you.
yes, starting with the Figo classification of fibroids, why it matters. Are the slides moving?
No.
First, yes,
Yeah.
yes, it is moving, ma'am.
So what is it coming to? What is the Figo classification? It is a system for the classification of uterine leiomyomas based on their location. So what did we traditionally learn in the past when we were doing our MDs? We were told that there were just 3 basic types: submucosal, intramural, subserosal. Now, a classification system that reported basically the relationship of the fibroid to the mucosal surface of the uterus. And this was introduced more than 20 years ago. And this is what we had learned. Why was there a need for a newer classification? Now we know uterine fibroids are the most common reproductive tract tumors and are prevalent in almost up to 80% of the women by the age of 50 years. The Figo system advanced the level of standardization in evaluating these women with abnormal uterine bleeding. The Figo classification basically subdivides fibroids basically into submucosal, other, which includes intramural and subserosal, and the hybrid types. Precise classification is important for appropriate surgical planning and ensuring a better outcome. And it also has a role in the post-treatment setting in order to assess the treatment response, what is the change in the overall tumor burden, and whether there is any recurrent lesions occurring or not. So just in brief, what is the Figo classification? So we start with 0, which is basically a pedunculated submucosal fibroid. 1 is a submucosal fibroid, which is less than 50% intramural. 2 is again submucosal, but more than 50% intramural. Third fibroid is completely intramural, but it is abutting the endometrium. Fourth is again intramural with no contact with either the endometrium or the serosa. So it's a true intramural. Coming to 5, 6, 7, these are basically subserosal fibroids. So subserosal 5 would be more than 50% intramural. Subserosal 6 is less than 50%. 7 is what we call as the pedunculated subserosal fibroids. Then there's another classification. 8 is for other locations, that is cervical, parasitic, broad ligamentary are all included here. 2 to 5 are basically included in the hybrid, which extend from the submucosa to the subserosa. So this is the basic classification, and this is the ultrasonic representation and how these fibroids would look like. So if you see 2 to 5, they go from the submucosal right up to the serosa. And so did it matter? What was the need for this classification? So whenever we think of managing a fibroid, the important things to consider are what are the symptoms, what is the location, relationship of the fibroids to the submucosa and the serosa, and what is the size. So when we consider management, we basically consider 2 basic things. Has the woman completed her childbearing, or yes or not? So if she's not completed her childbearing, the options left with us are medical, uterus conserving surgeries. We have to consider what is the impact on fertility, whether the surgery should be done open, hysteroscopically, laparoscopically. If the woman has completed her childbearing, is she desirous of conserving her uterus? Because that is her choice. And does she need hysterectomy, again, open or laparoscopically? So when we talk about Figo 0, these are usually pedunculated intracavitary fibroids. They are attached to the endometrium by a vascular stalk. So the treatment here would be basically hysteroscopic resection. Now coming to 1 and 2, 1 we know is more than 50% submucosal, and 2 is less than 50% intramural. So treatment offered here is hysteroscopic myomectomy, but it is very important to differentiate between the 1 and 2, because what is the intramural extent? If it is a large Figo 2, which has more than 50% intramural component, the hysteroscopic removal will become difficult. And it is also important to assess the distance between the intramural component and the serosal surface. So this is where the role of Dr. Sonal would come in. And the distance, if it is less than 0.5 centimeters, there are reported incidences of higher chances of rupture during hysteroscopic resection. So when we talk about Figo 3, these are 100% intramural with endometrial contact. And 4 is there is no endometrial or subserosal. So you need careful resection during laparoscopy and laparotomy, taking care so that you don't open the endometrial cavity, provided there is enough distance from the submucosa to prevent a transmural incision. So safe resection of Figo 3 becomes more difficult because it is closely abutting the endometrium. Now 5, 6, and 7, like we discussed, are subserosal. These are usually asymptomatic, may cause pressure symptoms when they become large. Treatment options include uterine arterial embolization, resection, laparoscopically or laparotomy, and lastly, a hysterectomy. Figo 8, extrauterine, cervical, broad ligament, parasitic. Hybrid are basically denoted by X and X. So the first X is the extent where it is close to the submucosa, and the second X is the distance, how far it is from the serosa. Treatment here again varies from uterine artery embolization, focus ultrasonic, and hysterectomy. Now, is all good with the Figo classification? Is it reproducible? Are there any limitations? Now, Figo classification, a system has provided the clinicians with a more standardized framework for describing and characterizing the uterine fibroids. But what we have observed, there is a significant inter-reader variability. The Figo fibroid classification is not consistent amongst various fibroid consultants with a lot of experience. So Laughlin, Tomaso et al. Also noted that increasing size and number and the classifications became more discrepant among clinicians, basically because there is distortion of the normal anatomy and the landmarks, and this led to misclassification, leading to an improper surgical planning. And this variation was almost as high as almost 36% of the fibroids. So when we talk about fibroids, so that would be my last slide. I think this is basically, Figo classification is important, but what we need to do is we need to classify it. We need a good radiologist. And I think in the next talk, Dr. Sonal will be telling us how to be sure as to where and how many fibroids are there. We need your radiologist to map the fibroids so that when we enter the abdomen, we are very well prepared as to how to go about it. Thank you so much.
Hello. Yes, Sulekha
Hello.
madam. Yeah.
So
So
thank you so much. Thank you so much, ma'am. I think that was on perfectly on time. Sulekha
Thank you.
ma'am, if you want to
Thank
make a
you.
quick comment, so we'll proceed to the next speaker.
Thank you very much,
then
Dr.
Pushpa to
Ritu, for
introduce.
your wonderful and timely presentation. And we are really thankful to you. So let us
Thank
switch
you.
on to the next speaker.
Thank you, ma'am.
Shall I
Thank you.
to introduce the next speaker or somebody else?
I'll request Dr. Pushpa ma'am. She has also joined in. Pushpa ma'am, will you please introduce our next speaker, Dr. Sonal Panchal?
सोनल का स्लाइड दिखाओ नीलिमा. हाँ, इनको अनम्यूट करो. टेक टीम गौरी, सोनल को अनम्यूट करो. हाँ. Yes, Pushpa, please. No, Dr. Nilima. Sonal is the speaker. Yeah. Pushpa madam, are you with me? Dr. Pushpa Jungare?
Can't see her in the.
Yeah, she's there. Allow her to unmute. Technical team.
Yes, ma'am, she's already co-host.
हाँ. वो नहीं बोल पा रही होंगी तो
Ma'am,
सुमन से.
now you are
Yes,
unmuted.
ma'am.
Now you are unmuted actually, madam. Pushpa ma'am.
हाँ.
Hello.
Pushpa
Am I
madam.
audible now?
Yes,
Good
ma'am. Yes.
afternoon.
You
Welcome, ma'am.
introduce Dr.
After-
Sonal and conclude her talk as well. Yes.
Yes, after listening to Dr. Ritu, obviously the classification is very important, but we need Dr. Sonal Panchal, expertise of some sonologists like Dr. Sonal, so that we can make full utilization of that classification. So it is my pleasure to introduce Dr. Sonal Panchal. She is consultant at Dr. Nagori's Institute for Infertility and IVF Center, and she is National Academic Director, Ian Donald School of India, and she is having keen interest in infertility, gynec sonography, and 3D and 4D ultrasound. Dr. Sonal Panchal, it is for you.
Thank you very much, ma'am, for those very kind words. And as we have just 15 minutes, my thanks to everybody, the entire team led by Dr. Lakshmi. Thank you, Lakshmi. And starting with imaging for us, fibroids. TVS versus MRI, when and how? Fibroids, as we know, are well-defined benign tumors. They are formed of fibromuscular tissue. It is for that reason that they appear as hypoechoic, well-defined round, oval, or lobulated lesions, usually homogeneous, but the echogenicity of the fibroids may increase with the amount of fibrous tissue and the vascularity. And that is when we call it degeneration of the fibroid. Degenerated fibroids are usually heterogeneous in echogenicity, not necessarily always hyperechoic. There may also be cystic degenerations of the fibroids. As we know, they may be the hyaline degeneration, myxoid degeneration, red degeneration, which is very common with pregnancy. And these are all because of, I would say degeneration is a bit of a misnomer because these are all because of vascular derangements that occur in the fibroid. Some fibroids may also get calcified following necrosis. And these may appear on ultrasound. They have a very typical picture. Say, for example, there you have a cystic anticoagulation inside the area inside the fibroid, and that tells you, yes, this is a cystic degeneration. Or there may be a lot of vascularity and it may be a red degeneration. Yes, it is true, though, that cystic degeneration, calcification, we can easily identify. But when it comes to myxoid or a hyaline degeneration, these degenerations are very difficult to identify and correctly denominate on the ultrasound alone. Apart from the presence of the fibroid and heterogeneous or homogeneous ecotexture and the shape, which may be round, oval, or lobulated, it is further important that when you describe a fibroid, you should also describe the rim of the echogenicity of the rim of the fibroid, whether it is hypoechoic, as you're seeing here, it is calcified, or it is isoechoic to the remaining myometrium. It is this which decides its growing potential. Moreover, when it comes to the fibroid, we need to give you a correct measurement as discussed in the previous presentation. And the correct measurement, you should locate the fibroid, rotate the probe, and find out the longest section of the fibroid, freeze it on one frame of the dual frame. From there, just take a 90-degree rotation without no other movement of the probe, and then take the transverse section of the fibroid. On the long section, measure the longest diameter perpendicular to the long diameter, and on the transverse section, measure the longest side-to-side diameter parallel to the x-axis. Remember here that the long axis of the fibroid may always not be the long axis of the uterus, and therefore correct measurement of the fibroid is very important even if you're doing just a 2D assessment. Apart from this, especially when we have degenerated fibroids, there is a high chance that you may miss it. An adenomyoma and fibroids may get mixed up. And it is in these cases that there are certain signs which are going to help us. We are going to enumerate them all together, but shadows are one of the very important 2D characteristic of a fibroid. Fan shadows, that is alternate hypoechoic vertical strands that you see in adenomyosis, is not typical of adenomyosis. It is typical of myometrial lesions. But when it comes to fibroid, there is an additional final bold hypoechoic shadow, which is called the edge shadow, which is typical of a fibroid. So fan shadows as well as edge shadows is what you see on the 2D ultrasound for a fibroid, which is typical. Edge shadow is a typical of a fibroid. It is because of displacement of the muscle fibers and the curvature formed there. When it comes to Doppler, the peripheral vascularity, as we know, is typical of a fibroid. This vascularity is not a capsular vascularity. It is a pseudocapsular vascularity. It is actually myometrial vessels which are pushed to the periphery. Therefore, they have the same resistance as the normal myometrial fibers, usually between 0.54 to 0.58 RI. But when the RI may differ, when there is degeneration, it may differ depending on the position. Therefore, I'm not going to discuss that in detail here. The peripheral distribution is what is important, and that is typical of the fibroids, it has a high sensitivity and specificity for the diagnosis of the fibroid, just as one sign. But it is important to understand that apart from the peripheral vascularity, whenever there is a degeneration, that's when you will also find internal vascularity in the fibroid. Now, this is very different from the vascularity that you see in an adenomyoma or an adenomyosis. Here you have a peripheral vascularity, and the vessels which are inside, they are absolutely limited by the peripheral vessel. They do not extend beyond that, and that is what is called intralesional vascularity, whereas for the adenomyomas, the vessels, they do not respect the margins of the lesion. They disregard the margins of the lesions and they run through and through, and that is called translesional vascularity. So both of these lesions, though they appear very similar in echogenicity and very similar in presentations and symptomatology, they are still different. The Figo classification has been in detail explained. I'm not going to repeat it again, but just want to tell you that whenever you locate the fibroid in the uterus, that is when you are on ultrasound, that's when you are going to definitely talk about the penetration of the fibroid by the Figo classification. Say, for example, a very quick overview to this. This is an endometrium here, and you're seeing the fibroid. The endometrium is extending here. The fibroid is completely inside the endometrium. Here you are seeing another fibroid which extends right from the endometrium to the serosa, which is a hybrid fibroid. You are seeing a fibroid here with an endometrium more than 50% inside, which is type 1. And here it is a purely intramural type 4. Here it is an intramural fibroid which is touching the serosa type 5. Again, another 2-5. And here a type 6 fibroid, and here a type 7 pedunculated fibroid. So then especially, that means the penetration can be decided by ultrasound, 2D ultrasound. But whenever you are typically talking about type 4 fibroid, apart from the type of the fibroid that you mentioned, it is very important to mention what is the minimum distance of the fibroid from the endometrium and what is the minimum distance of the fibroid from the serosa. And this, remember that it will always not be in the same line. Sometimes the minimum distance from the serosa may be in a different plane than the minimum distance from the endometrium. And this needs to be correctly measured and mentioned, because that will help you decide the route of surgery. 3D ultrasound may do it in a much better way. As you can see here, the distance beautifully measured from the endometrium to the serosa. And moreover, when you're doing a 3D, you will also know the exact plane in which the distance is the minimum. You may also use typical the specialized 3D softwares like Scenic Calculation, as you're seeing here, and Magic Cut, which would help you exactly locate the position of the fibroid. Not only that, whenever we are talking about fibroids, and even if it is intramural, it is very important to also mention its relationship with the cornu, because cornual distension, cornual distortion is something very important, which would affect the prognosis of the patient as far as the fertility is concerned, along with the presence of the fibroids. So 3D ultrasound plays a very important role for the cornual or paracornual fibroids, for endometrial fibroids, that means for type 01 and 2 fibroids. And as you can see here, it gives a very beautiful idea about the distortion and invasion of the endometrial cavity. A large fibroid here, which is distorting the endometrial cavity from the fundus, the similar here. So those are the large fibroids where the ultrasound plays a very important role to exactly find out how much is the distortion and what is the amount of the residual endometrial cavity, intact endometrial cavity. 3D TV has successfully detected every case of a submucous myoma and uterine abnormality. And when it therefore comes to submucous fibroids, there is one important thing that I need to tell you. Yes, it is true that we can very beautifully on 3D ultrasound identify the type O, type 1 and type 2 fibroids, but type O fibroids are very commonly mistaken for a polyp. Remember, fibroids are hypoechoic. They are almost similar in echogenicity as the intervening area in a periovulatory endometrium, and therefore they may often be missed in the periovulatory phase, except if you have documented the distortion of the central line of the endometrium and on the 2D ultrasound, but it is these fibroids which are much better identified on the secretory phase, because the endometrium is hyperechoic and the fibroids will be very beautifully seen, whereas polyps are always better seen, the echogenic and always better seen in the periovulatory phase. Moreover, look at this beautiful folding of the junctional zone, which can be only seen on the 2D ultrasound, which can be only seen on the 3D ultrasound in the type O fibroid, which is a very important differentiating point from the polyp. Polyp will have intact junctional zone, and of course, fibroids will have a peripheral vascularity, and the polyps will have a single feeder vessel. It is for these fibroids that you can also use the step W classification to decide the surgical routes, and I'm not going to discuss that. And here, this is the same thing that I told you: single feeder vessel, rim of vascularity, intact junctional zone, infolding, and secretory phase for a better visualization. We have already talked about the two chief differentiating points between the adenomyoma and the fibroid, of which one is the, of course, one was the edge shadows and the fan shadows here. Edge shadows for the fibroid. The second was the peripheral vascularity with the internal vascularity for a fibroid, and the translesional vascularity for the adenomyoma. The two additional ones are here very important. If there is a fibroid, there is going to be a displacement of the junctional zone. It will never be a obliteration or breaking of the junctional zone. Now, moreover, one more sign is the margins. The margins may be not very clear, not able to. The margins may be fairly defined in the adenomyoma and very well defined on fibroid. Moreover, a very important modality now, elastography, must be used, which is an extension of an ultrasound, must be used for differentiating between fibroids and adenomyomas. Fibroids are always dark blue, which indicates a firm texture, whereas adenomyomas, they are usually green or yellow, which indicates a softer consistency of the lesion. So that is one more modality which can help. And still one more is injecting ultrasound contrast. When you inject ultrasound contrast, that is when the fibroids, they are going to first enhance the margins, and the margins are always going to appear very, very sharp and clear, and then the contrast spreads into the degenerated fibroid or in a fibroid. Whereas when you see the adenomyoma, you can beautifully see short linear vessels, first enhanced perfusion pattern, uneven contrast agent distribution, as you're seeing here typically, and there is unclear boundary. There's no boundary. So if you look at this, there's a clear boundary for the fibroid, no boundary here. There is asymmetrical distribution of the contrast here with percolates inside. Here it is peripheral and then just internal vascularity. So the contrast enhanced ultrasound is a very useful another additional modality for differentiating between fibroids and adenomyomas. Saline infusion sonohysterography makes easier to visualize the fibroids and other abnormalities if they are intramural. And very importantly, when you do a sonohystero, if you observe the angle between the fibroid margin and the endometrium, if it is an acute angle, it is mostly a polyp. If it is an obtuse angle, as you are seeing here, it is mostly a fibroid, though there may be polyps which are sessile, but this is a small percentage. Most of the times it is just the angle which may be helpful to you to differentiate between the two. You can see here beautifully the angle between the polyp, and here also there's an angle between the polyp, though the polyp is large, between the endometrial cavity and the polyps. So that is one of the very important signs to differentiate polyps from fibroids. Apart from this, now as Dr. I'm sorry, I forgot the name, the previous speaker, she did talk about the mapping the fibroids. Yes, when it comes to mapping the fibroids, remember when we report the fibroids, it's important to mention the type of the fibroid, that is the penetration, the shape, the location. whether it's upper, middle, lower third of the body, anterior wall, posterior wall, or it is lateral walls or the fundus. It is important to mention the size of the fibroid in 3 diameters, ecogenicity of the fibroid reams, the distance from the serosa, distance from the endometrium, vascular pattern, and the vascular score. And you should make a complete table. The first fibroid seen on the image has to be described first in the table. And after that, you also do make a pencil diagram. Sorry, you also make a, I'm sorry. What is that? I don't know. Please. Okay, so you want me to stop? I'll stop right away, but so you need to make a pencil diagram again, along with the numbers of the fibroids. You can also use a very specialized software now, which identifies, and with AI, it actually locates the fibroid very clearly and tells you the relationship with the endometrium. These are the new softwares which are available on the ultrasound machines. Other modalities used for the fibroids may be X-rays, not very commonly used unless it is calcified. It's not of any use. CT scan can be used. It appears as a bulky, irregular uterine mass. Degenerated fibroids may appear complex and contain areas of fluid attenuation as marked by the arrows here you can see. But contrast CT may be useful to identify them better when it is, but it is MRI, which is probably even more used. Yes, when it's calcification, even CT scan is okay, but MRI is preferred imaging modality for characterizing uterine fibroids and identifying their exact anatomical location, especially in the cases when there's a confusion between adenomyomas and fibroids. Though now ultrasound signs are much more clearer, and MRI is less and less required. 2D ultrasound for localization of the fibroid is not an adequate tool, and therefore 3D ultrasound is used even more commonly. Even MRI can be useful for the same. And MRI the important point is MRI can differentiate between different types of degenerations, which is not confidently possible on ultrasound. So myxoid degeneration may show cystic spaces filled with gelatinous, with the gelatinous myxoid material between the smooth muscles. Hyaline degeneration, smooth muscle is replaced by the fibrous tissue, as you can see here, and less intensity signals, occasionally speckled, and less enhancement after the contrast. The cystic degeneration with a large hyaline it follows hyaline degeneration in a large cystic space inside, and a ray degeneration, which appears as hemorrhagic infarction of the entire lesion. So ultrasound is a primary investigation. Additional tools, Doppler, 3D ultrasound, CIS, and contrast improves visibility. CT scan is not usually done. MRI is the investigation, most commonly suggested in cases with poor visibility on ultrasound, difficult differentiation from adenomyoma, pre-surgically in cases of multiple fibroids. Thank you very much for the patient hearing.
Yeah, Pushpa madam, you can conclude, and Sonal, we will have one question to you after Dr. Farhana's talk. People
Sure.
are asking about role of elastography.
Sure.
So, Pushpa madam, once you conclude, then Suman can have the another talk. Yeah.
Yes, yes. Pushpa ma'am, can you quickly summarize so we can then go to the next session?
मैंने किया उनको ask to yes.
No, I am unmuted. Thank you. Very elaborate lectures, and the images Dr. Sonal showed, as if we are seeing it with eyes.
Thank you.
That
Thank
is
you,
a
ma'am.
Extremely
Sonal, I
useful
cannot
for
think
planning
of
surgery.
any other person except Sonal to speak on that topic.
Definitely.
Thank you very much. Thank you very much.
Yeah, Suman, please invite.
Yes. May I request Suman ma'am to please invite Farhana Diwan ma'am, Farhana Diwan, and to give a brief introduction of madam.
Technical team. हाँ, Suman को unmute करो. Suman, are you with me? सुप्रिया तुम
Yes, ma'am.
सुमन वो सुप्रिया तुम क्विकली इंट्रोड्यूस करके
Yes,
लेट्स स्टार्ट.
yes. Okay, ma'am. Okay, ma'am. It's again an honor to invite Professor Farhana Diwan, President of OGSB, Secretary General SAFOG, Professor, Department of OBGYN at IBN Sina Medical College. Yes,
No,
Suman ma'am is here.
Yeah,
Yes,
yeah.
sir.
You
Yes,
had
please
muted me.
unmute
I was not able to anymore. So good
Yeah.
evening, everyone. Thank you, Lakshmi Shrikhande madam, for giving me this very prestigious opportunity.
Suman, she has been already introduced. Let's have her talk and then you can conclude. Yeah. Nilima, please stop screen share.
Over to Farhana ma'am for her presentation.
Huh.
Meanwhile,
very
our delegates can put their questions in the chat box, so we can have a very interactive session after Farhana ma'am's session.
Okay, so
Yeah.
can I share my screen?
Yes, please. Yes, please. फरहाना, अरे टेक्निकल टीम थोड़ा अलर्ट रहो, अनम्यूट करते रहो. तुम म्यूट क्यों कर रही हो सबको? गौरी?
नहीं मैम, म्यूट नहीं कर रही हूँ, वो एक्चुअली डेलीगेट्स फिर बीच में बोलते हैं ना, इसलिए वो सेटिंग वैसे रखी है, बट कोस्ट किया है.
हाँ, तुम
I
सारे
would request कि आप ना नेक्स्ट सेशन पहले से चेक करके और जो भी चेयर्स और स्पीकर्स ऑफ नेक्स्ट सेशन है उनको को-होस्ट में डाल दो.
Yes,
5
ma'am.
मिनट पहले ही ना कंक्लूजन के पहले.
Yes,
Done.
ma'am.
Done.
हाँ.
Yes, Dr. Farhana. Yeah.
Yeah. Can you see my slide?
Yes, we can see. See whether they are moving at your end.
Is it moving?
No.
No, madam.
So you just stop share. I will try from my side. Farhana, stop. I will share.
Okay.
Yeah.
Okay.
I will be sharing her PPT. Just a second. Supriya, are slides moving? Supriya?
Yeah.
Yes, ma'am. Yes.
Yes, ma'am.
Yeah. Dr. Farhana, please start. Yeah.
Can you give the first slide, please?
Yeah.
Thank you very much. Respected chairs and dear audience, it is my great pleasure to be here and present in this ICOG Masterclass on Fibroids, Advances in Diagnosis and Management. I'm really indebted to Dr. Lakshmi for giving me this opportunity. So my topic is uterine artery embolization versus high-intensity focused ultrasound for treatment of uterine fibroid. We have, in the last two presentations, we have seen fantastic overview of the fibroid and also the sonographic details. So we know that fibroid is the most common benign tumor in women of childbearing age. And regarding the hysterectomy and the myomectomy, it is because it is an alternative. Hysterectomy has 10% risk. There are risks there, and myomectomy, in myomectomy, the fibroid may recur. So uterine anti-embolization is an option for women who wish to preserve their uterus and avoid the surgery at the same time. So this is an interventional radiological procedure which blocks the blood supply of the fibroid, but there are some complications like pelvic pain, nausea, vomiting. These complications may sometimes occur in these patients. And there is, regarding the future fertility, this is one issue which has to be considered because in uterine anti-embolization, there is the future fertility may occur. Can you show the next slide? High intensity focused ultrasound can ablate the, regarding the HIFU, actually what happens, there is the blood supply in the around the fibroid, so it will coagulate the fibroid. And the fibroid vessels can be sonicated and blocked by the HIFU spots. And fibroid devascularization may prevent the fibroid growth. Next. So this is the uterine anti-embolization where we can see the catheter, and when the catheter is inside, it comes from the anterior division of the internal iliac artery through the uterine artery, and here we can see that the embolic agent are then injected and the fibroid is devascularized. Next. So from where has this arterial embolization come? This has been during the last 30 years, it has been used for postpartum hemorrhage, bleeding postpartum hemorrhage after normal delivery or cesarean section, and also after following the gynecological surgery, and also for arteriovenous malformation as well. In 1991, it has first been used for the treatment of fibroid. Next. And from 2000, RCOG and the Royal College of Radiologists, they issued the guideline that, well, this can be used for the fibroid. And NICE has also accepted uterine anti-embolization for the treatment of symptomatic fibroid. Next.
So when do we do it? When the woman presents with a symptomatic fibroid, that is there, she has bleeding, and also there might be dysmenorrhea, dyspareunia or pressure effects from the urinary or gastrointestinal tract, and also in adenomyosis, actually not only per se, but if the adenomyosis is along with the fibroid together, then it may be. Next. There are some contraindications and there are some complications, as I already mentioned, that among the complications, there may be pelvic pain, there may be nausea, vomiting, or there may be fever or embolizing the other organs. So there are some absolute contraindications. If the woman has recent infection, because it might flare up, and if there's doubt of the diagnosis, it is asymptomatic, or there is pregnancy, then in those cases, it might be contraindicated. Next. So how do we do it? In this, we can see that there is right-sided percutaneous femoral arterial access is given, and then the catheter is introduced. It is a 4 or 5 French catheter. It is manipulated and through the fluoroscopic guidance into the uterine artery, as I mentioned, through the anterior division of the internal artery. Next. When it is positioned, the embolic agent is injected under the fluoroscopic control so that there is no reflux. And the opposite side is also done in the same way. Next. So it is good. 80 to 90% will be patients will be asymptomatic, and after 1 year there may be reduction in the size as well. And sometimes the complications appear late, maybe after 1 month or 1 year, like that. And sometimes in 3% cases, hysterectomy may be required. Next. Well, re-intervention may be required. Sometimes it might be so that there may be a need for uterine artery embolization. In 32% cases, it may be needed, and after 5 years of surgery. Next. Next. Treatment of fibroid. I've also already mentioned that regarding the fibroid, whether woman who wants fertility, it needs to be, we should discuss with the woman whether she needs the pregnancy or not, and then we can give it, because there might not be the chance of getting pregnant. And when we select the patient, we should do it by a multidisciplinary team, including the gynecologist. And of course, we know that the intervention radiologist is doing it. So that person must be very much competent to do this embolization technique. Next. So the radiologist direct referral from the primary care should be there, may be done, but of course we need the gynecologist to be involved, to be there during the procedure. An accurate pre-treatment diagnosis is recommended. Next. So this is the HIFU. Next. So it is a non-invasive technique where non-ionizing ultrasonic waves are used to heat or ablate the tissue. So it started in 1994. The machine came, and from 2004, it has been started and FDA has been approved it. Next. So we know that the fibroid has a peripheral vascularization. So what happens that we call it peripheral vascular capsule, and the inside is not so much vascular. So these vessels are sonicated. First, it is identified by ultrasonography and then blocked by the HIFU spots. And you have seen in the picture that the body of the woman is lying like this. And ovarian artery, sometimes it is also sonicated. And this is one thing that we have to do, that possibly because it is the sole vascular supply. Next. So it does not remove the fibroid, I've already mentioned, but it kills and coagulates there is coagulation, necrosis, and it shrinks the fibroid, and so the symptoms are relieved. Next. So there are some contraindications where HIFU cannot be done. If the patient has a history of radiography of the lower abdomen, radiotherapy of the lower abdomen, then there may be non-benign cervical or other gynecological disease, or there may be uterine sarcoma. And some women, they cannot lie in the prone position for the lumbar disc disease, then they can be done. Or if there is a suspected malignancy. Next. There are some contraindications. For example, the woman is very overweight, then there will be the thickness of the fat, which will prevent the material, the sono, the rays. And there, if the vertical incision is there, fibroid type 0 is pedangulated, it might not work. And patient has a history of abdominal liposuction, and sometimes the patient is not suitable for the anesthesia. Then maybe it may be a contraindication. Next. There are some advantages, and we can see that in the later I'll tell you that re-intervention is less and recovery is good. So it's a day procedure, non-invasive, faster recovery period, and the woman can go to work quickly. The non-ionizing radiation and procedure can be repeated, and the ovaries are not damaged, and it is cost effective. Next. So these are some of the complications which may occur. Next. So it is a safe option in the management of women with uterine fibroid. Next. So now I would like to compare these two. Next. Well, the UAE and the HIFU, they have been both have been approved by FDA. UAE is an angiographic intervention causing ischemia, myoma necrosis, and it treats the entire uterus, not only the tumor. And the symptoms are also with few complications. The symptoms improves the symptoms. Next. And I have already mentioned about the future fertility. Next. HIFU, I have already mentioned that there's coagulation necrosis, and there is ability process highest compared with that of other intervention. There is re-intervention is more. Next. So HIFU is relatively safe. I've already mentioned that. And comparing if you have this minimally invasive therapy for the treatment of uterine myoma is important area to guide clinical choice. But of course, we have to remember the long-term comparison. Next. And when we look into the quality of life improvement, both in UAE and the HIFU, the quality of life is improved. And the score is also less, and UAE and HIFU ablation indicates that the effect of UAE was superior to that of HIFU ablation in terms of alleviating the symptom. But a bit, in case of UAE, a bit improvement of the quality of life. So they were older and women who underwent HIFU ablation. It was different studies have shown the different patient profile. Next. So if we compare the both, approval from FDA was there, and I have mentioned that in UAE there is angiographic intervention technique, and in HIFU there's coagulation necrosis. And UAE it treats the entire uterus, HIFU treats only the myoma, it coagulates the myoma. Both are safe, and not recommended for UAE is not recommended for women to desire fertility, and HIFU doesn't affect the fertility. Symptom relief is equal in all, but quality of life is more better in case of HIFU and then compared to the UAE. Next. I think this is the last one. I have one more slide after this. Yes. So re-intervention is high in case of UAE, which is 32% I mentioned, but HIFU it is higher. And recovery time is more, very quickly the woman can recover in HIFU as compared to the uterine artery embolization. Next slide. And just I have mentioned in the next slide, UAE takes 2 weeks. Next slide. So we can see that hysterectomy, we know that our women take longer to recover in hysterectomy, myomectomy, etc., as compared to uterine artery embolism. It's 1 to 2 weeks, the woman is okay. And in the HIFU, it is only 1 to 2 days. So thank you very much for patiently hearing. And I think that we have had a chance to compare the two. Thank you so much.
Thank you, Dr. Farhana. It was really a very impressive and very insightful presentation of yours. And you have very nicely compared between the uterine artery embolization as well as the HIFU. And both the treatment modalities, I can say, is well comparable. But the thing is that availability depends upon where it is available. And because for that, a very tertiary setup is required, and the facility of the radiologist should be with the gynecologist as well.
Exactly.
And you have already said that hysterectomy takes a longer time to heal and to improve the quality of the life of the patient. But in these, by HIFU, it is only 1 to 2 days, and by UAE, it is within 1 to 2 weeks. So, but both, I think the HIFU is more costlier than UAE. So, yeah. But I have seen in Singapore and other, developed countries, they usually prefer the HIFU system. Even for the kidney stones and all, they prefer HIFU. But in India, there are many centers where UAE is being done. But it has to have a very good setup. So thank you very much for your
Yes, Sulekha madam, quick comment. Yeah, you want to say something? Unmute karo, please. Technical team, please.
Suman ma'am, please, can you make your comments? Then we will go with ahead with the queries.
गौरी तुम है ना प्लीज सबको co-host करके रखो, जितने भी नाम फ्लायर पे हैं, ऐसा नहीं करो.
I have already,
उनको ऐसा म्यूट अनम्यूट करने का नौबत नहीं आना चाहिए. आई एम नॉट एबल टू. सुलेखा मैडम अनम्यूट करो. तब तक सुप्रिया तुम 2 क्वेश्चन ले लो. एक रोल ऑफ इलास्टोग्राफी दिख रहा है कहीं मुझे सोनल के लिए.
Role of elastography, Sonal ma'am, the audience would like to know. Can you please enlighten?
Sure. So elastography is one of the extension or softwares of, or I would say an additional modality for ultrasound, which measures the firmness of the tissues. And it has a lot more in elastography. It's a subject by itself, but the qualitative elastography that we use to differentiate subjectively the firmness of the tissues, it presents as an entire color spectrum of the rainbow. The dark blue is the firmest tissue and the red is the fluid. So and you just have to as you do the scan, there's a minimal pressure, there's a pressure display as to your pressure is adequate or not. When your pressure is adequate, that is when you have to check the color of the lesion. And if it is dark blue, it is firm. If it is green or yellow, it is softer. If it's yellow, it's very soft. If it's red, it is fluid. So that's how you can differentiate between the different consistencies of the lesion. It is widely used for the differentiation between the malignant and the benign lesions, but it can be also used for fibroids and adenomasses. It has also been recommended now to be used for cervical assessment to decide whether the patient is likely to go into early labor or not. So that is elastography.
Yes, Sulekha madam, please.
Question again to Sonal ma'am.
Let me congratulate
Sonal ma'am in type 0 fibroid to differentiate with polyp.
Okay, type O fibroid differentiated from polyp. The size is not a criteria to differentiate between the two, but as I told you, polyp and fibroid, you can differentiate it one by its ecogenicity itself. Fibroids are comparatively hypoechoic as compared to the endometrium, whereas the polyps are ecogenic as compared to the normal endometrial ecogenicity. 2, you can put on a Doppler. The polyps have a single feeder vessel and the fibroids have a peripheral vascularity. And if you have a chance to use a 3D ultrasound, you need to see the lesion in the coronal section, and at different coronal sections, if you observe wherever the fibroid is indenting into the endometrium, you would see infolding of the junctional zone, whereas in the polyps, the junctional zone is intact. The infolding is because the fibroid it arises from the myometrium and protrudes into the endometrium, whereas polyps, they actually arise from the endometrium, so the junctional zone is clear. So those are the 3 chief differentiating points between the two. You can use sonohystero, and you can look at the angle between the base of the lesion and the endometrial surface.
So it seems
madam,
that
you want to say something?
There is one, madam, there is one question for Farhana ma'am also.
1 minute.
Supriya, just let Supriya. Yes,
Can
Sulekha madam.
Yeah, I want to congratulate Dr. Ritu, Dr. Sonal, and Dr. Farhan. And I want to conclude saying that every fibroid does not require medical and surgical treatment. So what is important is the beautiful classification, mapping, imaging techniques, which will tell us which patients they require conservative treatment and non-invasive techniques, and which patient require that the treatment that we have already discussed. So thank you all and for inviting me in this nice webinar. Thank you.
Yes, Sulekha madam. Pushpa madam, आपको
So
कुछ
finally,
बोलना है?
it seems that radiologists or sonologists, they have taken over the not only diagnosis, but sometimes management of fibroid also. Of course, we are totally dependent on them to decide the modality of treatment. That is very true. So
Ma'am,
we
I
need
would say the other way around. I would say gynecologists must always master ultrasound
exactly,
Yes.
exactly.
to treat the patients better.
Yes. So unless we are having our own machine, we are going to be dependent on you.
Ma'am, there is one question for
Yeah.
Farhana ma'am.
Yes.
Whether HIFU is effective in adenomyosis and what is the cost effectiveness for both the procedures?
Thank you for the question. HIFU is not, I haven't seen in the literature regarding the effectiveness of HIFU in adenomyosis. And you know that adenomyosis is scattered. In adenomyosis, the thing is scattered. But in HIFU, you know, they will be just sonocate the margin and then give the spleen. So I think that it will not be so effective in adenomyosis. And regarding the cost, the HIFU is more expensive as compared to the uterine artery embolism. And also embolization has been in use for a long time. It is after many years, HIFU is only recently it has started. So it will become less costly over the time. Thank you so much.
And also, madam, uterine artery embolism is applicable for which type of fibroids? Which fibroids it can be used? Ma'am, please unmute yourself.
Any fibroid it can be used. It's not that.
There's a limit of size, madam, I think.
Yeah, exactly.
More than 20-week size of the uterus.
Very big, then it will be difficult.
Will be ineffective. So it has to be.
It is about all the questions in the chat box. If any other questions, otherwise we can move with the second session, and I will hand over to Dr. Prachi for convening the second session too. And a big thank you to Lakshmi ma'am and entire team for making me a part of this exercise. Thank you so much. It was a wonderful learning
And
experience.
thank you everyone for giving me this opportunity.
Thank you, dear all. Thank you. Prachi, let's
Over
start.
to you, Prachi.
Yes. Yes, thank you so much, Supriya ma'am. After the wonderful session 1, we move on to session 2 and not encroaching any of the speakers' time. Just revising the rules once again, request to chairs to keep it crisp, request to speakers to finish on time, and request to audience to please post your questions in the chat box on time. I will welcome our respected chairs for this session. We have Dr. Ramprasad Dey, sir. Sir is professor of Kolkata in OBGY, of course, in Kolkata Medical College. He is editor-in-chief, Indian Journal of Perinatology and Reproductive Biology. And there is an endless list for others to read. Welcome, sir.
Yes,
The next
thank you.
chair is, thank you, sir. Dr. Rakhi Singh ma'am. She is director, Abalone Clinic, Maternity and Fertility and IVF Center in Noida. She's president of Noida Society. Welcome, ma'am. And Dr. Shanta Durge, ma'am. She is director and chief consultant of Durge Clinic at Basav Kalyan, nominated member to Karnataka State Supervisory Board, PCP and DT cell. So I will invite Dr. Ramprasad, sir, to please introduce our first speaker and also conclude the session of the first speaker.
Yes, thank you, Dr. Prachi, and good evening to everybody, respected all. It is my privilege and honor to be here and in this prestigious ICOG Masterclass. I must express my sincere gratitude to Dr. Lakshmi Madam for inviting me. Madam does not require any introduction. The CV slide has been already shown. He is the immediate past chair from 2022 to 23, and he is also the honorary fellow of Royal College. And he also so many committee chairperson and the former vice president and also the vice president of ISOBAR. And we are eagerly waiting to hear from the madam the medical management of basically uterine fibroid. All of you know the fibroid and hysterectomy and the rising trend of hysterectomy in India. what are the Supreme Court verdict, what are the audit, everything is there. So the medical management is very important. So Madam, floor is yours, please.
Yeah.
Yes.
And see what happened. I just shared Dr. Farhana's. You all can see my screen?
Yes, ma'am.
Can see you, but it is not in the slide. Yes, click in the
See,
slide. So
now you all
yes,
can see this is in the slideshow.
Yes, ma'am.
yes, it is
Yeah,
okay.
and slides are
Perfectly.
moving. So friends,
Yes,
now my previous speakers has already told you that it is one of the commonest benign tumor. But despite the high percentage of fibroids, only 20 to 30% they will become symptomatic, and symptoms have already been briefed. What I'm telling you about the pathophysiology, because unless and until we pay attention to pathophysiology, we will not understand the newer methods of medical drugs which are now available, how they are acting on fibroids. So first and foremost, we all must understand that these leiomyoma cells within a tumor, they do not rapidly proliferate, but rather the increase in tumor size is secondary to the production of an excessive, stable, and aberrant extracellular matrix made of disorganized collagens and proteoglycans. As a result, medical management should induce leiomyoma cells towards dissolution of this extracellular matrix as well as halting or inhibiting the cellular proliferation. We all know that gonadal hormones, they induce and maintain the leiomyoma growth via the production of this aberrant extracellular matrix. Therefore, research has focused on the development of medical agents to circumvent this steroid influence in an effort to reduce the fibroid size. Now I am talking of the newer medicines which include centrally acting GnRH analogs and peripherally acting agents which include aromatase inhibitors, antiprogestins, and selective progesterone receptor modulators. Whenever we are talking of these agents, naturally we are talking of the medical management of fibroids, and the indications are women who want to preserve uterus, who are keen for pregnancy, who are not fit for surgery, and where surgery is not indicated. What these medical therapies do? They control the symptoms, they reduce the fibroid volume, and if woman is having HMB, they reduce the menstrual blood loss. COCs, they have very limited value. Only advantage is their accessibility, oral administration, and low cost. LNG-IUS, yes, they have a limited role in myoma-induced HMBs, but remember the rate of expulsion is higher if you are using LNG-IUS for myoma-related HMB. We have a Foxy expert opinion on LNG that it can be used for intramural myomas in those women who do not desire pregnancy in near future. Now let us come to understand the role of GnRH analogs. GnRH, we all know, is released from the hypothalamus in a pulsatile manner, stimulating the anterior pituitary to secrete FSH and LH. In turn, they drive ovarian estrogen and progesterone production, which in turn stimulates the fibroid growth. So suppressing GnRH leads to hypoestrogenic state, reducing fibroid size and symptoms. We have GnRH agonist and GnRH antagonist. Agonist, they are primarily used as either preoperative therapy or as transitional therapy for patients in late menopause as they move towards menopause. We have good quality data to say that GnRH agonists, they decrease the uterine fibroid volume and increase hemoglobin values. However, when you are prescribing GnRH agonist, always remember the side effects for this GnRH agonist. Now it is the GnRH antagonist which is the game changer in fibroid therapy. It has emerged as a significant pharmacological innovation which causes rapid suppression of estrogen and progesterone with better tolerability than GnRH agonist. We have elagolix and rigolix. When we talk of elagolix, It has got two distinct main advantages over conventional GnRH agonist. First, it is an oral medication, and second, these oral antagonists, they have a short half-life, which allows a more rapid elimination from the system if you wish to discontinue the treatment. It is available in the market as Elagolix 150 mg tablet and as 200 mg tablet. This has been approved by FDA in May 2020 for the treatment of fibroid-related HMB for the maximum duration of 24 months. The benefit of ADVAC therapy is that it mitigates many of the hypoestrogenic side effects of Elagolix. But remember, when you are using ADVAC therapy, the effect of Elagolix on fibroid reduction is also attenuated. These are various studies which has been published. I am just quoting one paper which was published in 2022, where they have used Elagolix versus placebo, and they have prescribed it for duration of 3 to 6 months, and they have clearly concluded that it appears to be effective in reducing the HMB caused by fibroids. How long? I already told you, maximum you can give it for 24 months if you are using 150 mg OD. If you are using Elagolix 200 mg BD, then maximum duration is for 6 months. Whenever you are prescribing Elagolix, regular liver function test or monitoring is mandatory. So you have to exclude pregnancy. She has to take it at the same time. Use the lowest effective dose, taking into account the severity of symptoms. Limit the duration of use. If she misses the dose, she has to take it as soon as she remembers. Contraindications are pregnancy, known osteoporosis, known hepatic impairment, and of course, known hypersensitivity reaction to the Elagolix. Remember, bone loss is the significant side effect, but only if you are using it for a prolonged duration. This is very, very important for you to know and to counsel the patients that women who are on these agents, they may experience a reduction in the amount, intensity, or duration of menstrual bleeding, which may reduce their ability to recognize the occurrence of a pregnancy in a timely manner. So if you suspect pregnancy, do pregnancy test immediately and discontinue the treatment immediately. Your woman should always use non-hormonal contraceptives when she is on Elagolix, and also she should continue using these non-hormonal contraceptives for 28 days after discontinuation of the treatment. Whether she can use it during lactation, there are no concrete data, no studies published which can show you that Elagolix is excreted in the milk. As with any other drug, it does has a share of undesirable side effects, but they are mild and they are very common side effects in the form of nausea, headache, pain in abdomen. Do remember the drug interactions, hormonal contraceptives I have already briefed, then cyclosporin, rifampicin, and warfarin. If you are using ADVAC therapy, that is Elagolix combination therapy, then ovulation suppression does occur with this therapy. But this ovulation suppression is variable, and therefore this combination therapy should not be taken as a contraceptive. Prescribe non-hormonal contraception along with Elagolix combination therapy as well. Now we have another GnRH antagonist in the block, that is Relugolix. This is also approved by FDA in May 2021 for the treatment of fibroid-related HMB for a period of 24 months. A distinct advantage of Relugolix is its once daily dose and potential for greater reduction of pain and bulk symptoms as compared to Elagolix. This is the study which has shown clearly that Relugolix is effective in this indication. The NICE guidelines have also said that you can use Relugolix for this indication. Linzagolix is another GnRH antagonist. It is available in 100 mg tablet, or you can use it 200 mg tablet. The dose is OD. and it has the option of being administered with or without add-back therapy. Again, there are various studies which have shown the safety and efficacy of linjagolix. The benefits of GnRH antagonists are many over traditional treatments, that is rapid symptom relief, no estrogen surge or flare-up which you see in agonist, oral administration, lower risk of severe menopausal symptoms, and they can be used up to 24 months. Selective estrogen receptor modulators we are not using in our day-to-day practice, so I am going straight forward to the selective progesterone receptor modulators. They are the ligands that have selective progesterone agonist, antagonist, or dual activity on progesterone receptors. These medications are mifepristone and ulipristal acetate. The recurrence of fibroids is reduced for up to 6 months even after you discontinue these treatment. In addition, these agents, they do not affect the bone mineral density. This is how they act on fibroids. They decrease the fibroid size and volume. On HPO axis, they inhibit ovulation, and on endometrium, they cause amenorrhea. So talking about ulipristal acetate, lot many trials are conducted on ulipristal acetate, like Pearl 1 trial, then these authors only continued a non-inferiority trial. So taken together, all these trials, they provided sufficient evidence for the regulatory agencies of the European Union to approve ulipristal acetate as a pre-op treatment for symptomatic fibroids, whereas it is still not FDA approved. What about our own DCGI? It was approved in 2018 for preoperative treatment of moderate to severe symptoms of uterine fibroids. Then in 2020, there was a case of liver injury which was reported. So it was called back and DCGI said no more marketing and selling of this drug. But in 2022, again, the suspension order was revoked and now it is available and approved by DCGI that it can be used in a dose of 5 milligram under restricted use. And liver function test should be done prior to prescribing the drug, and you have to do every 15 days LFT when your woman is on this drug, and you have to stop it the moment you see elevated liver enzymes. Then I was going to the review. This is the recent review published in 2024 where they have said that you can use ulipristal acetate in 2 conditions. That is the preoperative treatment for those women who are having fibroid of 3 centimeter or more, and intermittent treatment in women who are not eligible for surgery, for example, where the risk of surgery outweighs the benefits. What dose you can use? It can be used in a dose of 5 milligram for up to 4 courses in women with heavy menstrual bleeding. So you can see that if you are giving the 5 milligram, this is the study published, you can start a woman on 5 milligram of ulipristal acetate, give it, and in between courses, you should have a gap of 2 menstrual cycle, and always start it on day 5 of the menstrual cycle, and it is well tolerated, efficient, and safe. There are various advantages of these agents. They retain fertility, they provide symptomatic relief, they allow for fertility treatment, and they prevent the recurrence of fibroids after surgery. Aromatase inhibitors, there are several studies which has revealed that uterine leiomyoma cells, they harbor intrinsic aromatase activity, thereby providing a direct source of steroid hormone to drive further growth through the development of an aberrant extracellular matrix. And that is how interest was generated in the aromatase inhibitors. But in the absence of well-designed trial, this has not been approved by FDA, so we are currently not using it in our day-to-day clinical practice. Then we have antiprogestins. They have been shown to be elevated within leiomyomata as compared against adjacent myometrium, and taken together, these points, they make inhibitors of the progesterone an area of interest for the medical management of leiomyoma. Mifepristone, which is also known as RU486, is the most extensively studied progesterone receptor antagonist in leiomyomata. You can use it in the dose of 5 to 15 milligram for 3 to 6 months, and it has been shown to decrease the HMB, and in some studies, the fibroid volume was also reduced. But because of the unopposed estrogen stimulation, concerns are there about the endometrial hyperplasia, and here also this drug has not been approved by FDA. Another promising innovation which has come into this field is the role of statins, that it can also, statins, they cause apoptosis and they suppress the growth of fibroid cells via calcium dependent pathways. So friends, the key takeaways from my presentation is symptomatic uterine fibroids, they require surgical and or medical therapy according to the Figo classification, severity of symptoms, patient's age, infertility, and wish to preserve fertility. Decision about uterine fibroma treatment must balance the risk and benefits, and they should be individually based on patient's medical conditions, symptoms, and her wishes. New drugs, that is oral GnRH antagonist and ulipristal acetate, are now DCGA approved and FDA approved, and these two drugs are the game changer in the medical management of fibroids, which has proved their efficacy and safety in the medical management. Thank you. Thank you so much for your patient hearing.
Thank you, ma'am. I would request Day sir to please conclude the session.
Thank you, madam, for your elaborate discussion. For the medical management, we have a little experience with the elagolics. Otherwise, other drug we are using. So it will be time will prove how much this drug will be helping to managing uterine fibroid. It is a beautiful discussion because the medical management is the keystone now, because fibroid is a disease where mostly the women suffering from the disease, not any mortality, morbidity. So for the morbidity correction, doing hysterectomy like major surgery is not most of the time is recommended. So thank you for your elaborate pharmacotherapy for the uterine fibroid. Thank you, madam.
Thank you so much, sir. For the next talk, I invite Dr. Rakhi ma'am to please introduce the next speaker.
We will take questions at the end of all the three talks. Yeah, please
Yes,
keep posting your questions.
Yeah, we have few questions for you, ma'am.
Yes.
We'll take at the end of the session.
Yes.
Ma'am, please unmute yourself. Yeah.
It's a great privilege to invite Kalyan Varmet, who is a person who has lot of knowledge and well connected to everybody. Sabke saath dil se. At present, he is holding the post of president of IAGE for 25-26, and he was the secretary of IAGE from 23 to 24. Initially, he was a chairperson of the infertility committee of AMOGS and executive managing committee council of IAGE Maharashtra. Before that, he was also a public awareness committee of FOXY from 19 to 22, and he's done numerous amount of work, a humongous work and well-known figure who's been well renowned and known to all of us for Dil Se. Over to you, Kalyan.
Thank you, ma'am, for this nice introduction. My screen is audible.
Yes, we can see.
Yeah. Thank you for this opportunity. I'm going to talk on
Kalyan, it is not in slideshow.
Yeah, that's what I'm trying. Yeah.
Yeah.
So this topic has been given to me when I was about to look into this topic. I was slightly amazed that I'm supposed to talk on hysteroscopy, open lab, and robotics, and when to show the videos. So I have tried to conclude in 15 minutes time. My time starts now. So what are the indications of myomectomy? As such, it is indicated in infertility where there is distortion of the uterine cavity, in cases of submucous fibroid, which interferes with the fertility and should be removed in all infertile patients, regardless of their size and symptoms when it is submucous. Intramural, when it is distorting, reduce the chance of conception. And in non-distorting, whether to remove or not to remove is a controversial thing. In subserosal, no evidence supports removal in asymptomatic cases except infertility, where there is no other cause is found. And whenever the size is more than 7 centimeter, multiple fibroid more than 3, which are ranging 3 to 5 centimeter in size. Fibroids and subfertility go hand in hand. We have to see the position, whether it is near the cornu, whether it is submucosal or intramural, which is indenting the uterine cavity. The pressure effects are there or not, and whether it is blocking the tubal ostia, and also it causes cytokine production and poor implantation failure. This Figo leiomyoma subclassification is very important to understand where to do myomectomy and where not to do myomectomy, what should be the route. So anytime the myoma which is 0, that is pedunculated completely intracavitary, it is important to do submucosal hysteroscopic myomectomy. When it is less than 50% intramural, you can still go ahead with hysteroscopic myomectomy. But G2, which is more than 50% or equal to 50% intramural, then you have to go for a laparoscopic myomectomy. Other classifications are there, that is G3, 4, 5. These are all for either open or lap myomectomy. There is a hybrid leiomyoma which impact both endometrium and serosa, where 2 to 5, which is submucosal and subserosal, each with less than half of the diameter in the endometrial and peritoneal cavities respectively. This is very important figure for understanding, which is G0, that is hole is in the endometrial cavity. G1, which is more than 50% in endometrial cavity, and G3, G2 is more than 50% in the myometrium. Now for submucous myoma, which has to be removed by hysteroscopy, the Lasmer classification is very important, where it is depending on the points are given depending on the penetration, size, base, and lower third or lateral wall is involved or not. And group 1, that is 0 to 4 non-complex, 100% hysteroscopically. Group 2, 5 to 7, you have to counsel to the patient that you might require 2 settings, or if we are not successful, you have to go for a laparoscopy route. And group 3, 7 to 9, score always by laparoscopy or open technique. So hysteroscopic myomectomy, depending on the size of the myoma, you have to use resectoscope, or in some cases, you might have to do a laparoscopic approach also. Anytime you are doing a myomectomy, we have to know the location of the myoma, number of myomas, size of myoma, whether it's asymptomatic, symptomatic, associated adenomyosis or endometriosis, distortion of the endometrium, previous failed IVF cycles, previous pregnancy losses, available expertise and resources, which is very important. Anytime there is a laparoscopic route which is preferred by a laparoscopic surgeon, if you're not well versed or size is more than 15 centimeter, it's always better to do an open myomectomy, and other factors of infertility we have to take into care. Now the first variety I'm showing is a submucous G0 or T0 myoma, which is seen. So it is a myoma which is seen at the fundus. You can see this myoma, and we can do this myomectomy by hysteroscopy route by using saline bipolar resectoscope. You have to scoop the myoma from fundus towards the internal os. As far as possible, do remove the chips at the end. Don't remove in between. And initially, you have to use this, do these smaller myomas so that you can afterwards do submucous myomectomy for such large 6 centimeter to 7 centimeter fibroids hysteroscopically. But again, it has to be G0 always. That means it is there. It should be into the endometrial cavity. And you have to do this procedure as fast as possible, because it is going to absorb the fluid, which is not going to be good for the patient. And this patient might have symptoms of fluid overload. So you have to do it as fast as possible. Anytime in my practice, while doing such myomas, I tell to the patient that I might do in 2 settings. that is half now and half later, or I might go laparoscopic or laparotomy approach also if hysteroscopy fails. This is a resection of multiple myoma, newer technology called as hysteroscopic morcellator. That is hysteroscopic tissue retrieval system, that is called as STRS. In the first part, we have tried to remove it by resectoscopy. You can see this. And in the later half, we have to use the we have to use the STRS system if it is not completely removed. Then when to do an open myomectomy? Whenever the size of the fibroid is more than 15 centimeter, or size of multiple 3 or more fibroids which are more than 5 centimeter, or thirdly, you don't have a setup of doing a laparoscopic myomectomy. So don't be shy in opening the doing an open myomectomy. In our practice also, wherever the uterine size is more than 24 weeks, we straight away go with an open myomectomy whenever there are multiple fibroids. Uterine incision, as everybody knows, should be single. Anterior midline incision. Multiple incisions are not to be taken. You try to remove all fibroids from a single incision. The incision should extend through serosa, myometrium, and the capsule. Every effort should be made to remove all visible and palpable fibroids. If the endometrial cavity is breached, fine. The repair is with fine interrupted 20 vicryl and closure with 10 vicryl sutures. If the depth of myometrium is more, then you can take in 3 layers also. This is a very important figure which was there in textbook, that is Boney's hood, where you have to cut the fibroid and suture in such a way that fundus is completely sutured so that there is no defect. The important thing is there should be no defect so that hemostasis is good, because good hemostasis is going to give you good scar and less chances of rupture. Third is lap myomectomy. Should be less than 15 centimeter. Fibroid should be less than 5 centimeter. If there are multiple fibroids, surgeons loses the ability to palpate uterine tissue to detect smaller myomas because there is no tactile sensation in lap myomectomy. Incidence of rupture uterus is similar to open myomectomy, and incidence of adhesion is less than open myomectomy. Whenever you are doing a surgery, you have to know the vascular supply. That is very important. The upper part is by Orion artery and the lower part is by uterine artery, vaginal artery, and even middle rectal artery, that is the branches of internal iliac arteries. So those fibroids which are broad ligament, cervical fibroids, you have to be very specific while operating. In cases of broad ligament fibroid, whether it's a pseudo broad ligament fibroid or it's a true broad ligament fibroid. In true broad ligament fibroid, ureter lies medial to the fibroid. In pseudo broad ligament fibroid, because it's a subserosal fibroid which is going towards the broad ligament, the ureter displaces laterally. So you have to know this important stage. The savior for us while doing a lap myomectomy is a vasopressin, which is an endogenous peptide hormone. It causes plankning vasoconstriction, reduces portal inflow and reduces portal pressure. But you have to be very careful and see the pulse while you are using this drug. Ligation of uterines may be required whenever there are big and large fibroids are there. If fibroids are smaller, then there is no need of ligating the uterine artery. You can do uterine artery ligation at the origin. That is very important for us. Whenever there are large fibroids, multiple fibroids, you start dissecting, open the broad ligament fold, see where is the ureter and go medially, and then you see the uterine artery. You have to see the branches of uterine artery and you can do a temporary ligation of uterine artery for myomectomy. The incision is important to find the correct plane in any case wherever you are doing a laparoscopic myomectomy. The important is enucleation of the fibroid, which is done by myoma screw. There has to be a good traction. Do not avulse the myoma bed. and use of bipolar at the base because the active arteries are there at the base. Laparoscopic removal, you can see closure of myoma bed, 2-layer. If it is a big defect, you can do a 3-layer, and baseball sutures at the serosa. And nowadays in laparoscopy, we are using barb sutures. The preventive uterine artery occlusion can be done at broad ligament access to the uterine artery or posterior access to the uterine artery. And this is a good video of robotic surgery which is done, and you can see we are taking stitch at the uterine artery which is done, a ligation of uterine artery which is a temporary ligation which can be done for the surgery. Once you have finished the surgery, then you can remove the sutures by scissors and the blood supply goes back to the normal. Extraction of myoma is direct suprapubic extraction for smaller myomas, or posterior colpotomy, or electric morcellation that is done by in-bag morcellation. It is very important that those cases where suspected serosa, the in-bag morcellation is going to help you. And this is a smaller myoma where suprapubic incision is taken, and these myomas can be removed through the suprapubic incision in the endobag so that spillage is prevented, and in case suspected sarcoma is there, you can prevent it. Conversion to laparotomy, the incidence is though low. Factor increase the conversion rate are size of dominant myoma, anterior location, large intramural fibroid, or multiple fibroid. Here you can use pre-op GnRH analog so that you can reduce the size of the myoma. Recurrence after lap myomectomy rate is higher than laparotomy and time lapse before recurrence is shorter. It is impossible to palpate the myometrium thoroughly, and small intramural fibroid which doesn't alter shape of uterus might be missed, so recurrence is slightly more. Robotics assisted myomectomy is a newer procedure. It has advantages that three-dimensional image, absence of tremor, superior instrument articulation, comfort for the surgeon, and faster learning curve. These are few videos of robotic myomectomy where it is done. You can see it has a 360-degree angle so that surgeon can do the procedure sitting in an AC room, and docking of the instrument is done after the laparoscopic ports are put. You can see the precision in which it is done. It has a monopolar as well as bipolar current, but you cannot use harmonics in this. And even suturing is always better through robotics because the angulation is 360 degrees. And these are the multiple myomas which is seen. The procedure remains same, but because it has 360 degrees rotation, you can remove such pedunculated fibroids also through robotics. The pregnancy outcomes following robot assisted is that there are no spontaneous abortion, no uterine rupture, no significant modification of ovarian function was found after myomectomy. Conclusion is it seems to have favorable impact on the reproductive outcome of young patient with no impact on the ovarian failure. The pseudocapsule surrounding the fibroid is a fibroneuromuscular structure. An intracapsular fibroid nerve-sparing robot-assisted nanosurgery is helpful. Preservation of this bundle helps the better healing of the myometrium, minimal adhesion, and good post-op scar integrity. To conclude, lap myomectomy is a safe technique which has several advantages, including less post-op pain, shorter recovery time, and reduced post-op adhesion formation as compared to laparotomy. However, it is difficult surgery and surgeon needs to take training for the longer period. The last slide, the ever-changing future. Today we are at robotics. We never know. In future, we are at nanobots operated by clinical engineers or surgeons, and welcome to this new modality of nanobots. I am thankful to Dr. Lakshmi ma'am and ICOG for giving me this opportunity. Thank you so much. I have finished in time.
That was a wonderful timing, sir. Very lucid talk. Is Dr. Rakhi there? I don't see her in the pan.
Rakhi is
Yeah.
driving.
She
Thank
was
you,
driving.
sir,
We
for
can
this opportunity.
invite the, yeah.
No, I just want to
They said,
comment.
yeah.
It was a brilliant presentation, and we are really proud of you that you are now the president of IHG. The way you presented the lecture was really with the calmness and composure was something which I really admire. So keep
Thank
on doing good work that you've been doing for last so many years.
Thank you, sir.
And Kalyan, wait, we have questions. After this talk, we
ma'am.
will be having.
Yes,
Yeah.
ma'am.
Yes.
Yes.
Yeah. Prachi, just go ahead with the third talk. Yeah.
Yes, ma'am. For the third talk, I invite Dr. Shanta Durge ma'am to please introduce our next speaker, Dr. Ramala. Shanta ma'am.
Good evening to all. And today I'm going to introduce Dr. Amla Khopkar, Honorary Secretary General of African Federation of OBGY, and also Honorary Secretary General Emeritus. She is the member of Figo governing member, and she also received Figo award. So she is going to talk on differentiating fibroids from the sarcoma. So, ma'am, please.
Yes. Are you able to see my slides?
Yes.
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 Okay.
Dr.
Okay.
Amla
Hello.
Khopkar.
Make it slideshow.
Oh, yes, of course. So a very good afternoon to everybody, respected teachers, my colleagues, my friends. A big thank you and gratitude towards Lakshmi Shrikhande madam and Parag Baniwale sir for giving me this opportunity to meet you all again. It's always good to come home. So thank you very much. And I'm going to start my talk on why it is important to differentiate between fibroids and sarcomas. Murphy's law states that if anything is going to go wrong, it will go wrong. So I'm going to tell you a actual case presentation which happened in our unit. In 2019, I had a 54-year-old patient coming to me with...
Amla, sorry to interrupt you. Your slides are not moving.
No, I'm not moving them for a
Okay,
reason.
okay. I thought only first slide is showing. Okay.
No. So I'm just doing a case presentation. I had a 54-year-old para 2 living 2 patient coming to me with abnormal uterine bleeding on ultrasound. She showed a grade 4, category 4 Figo classification, intramural myoma of about 3 centimeters, but an endometrial thickness of about 1.2 centimeters. This was before COVID in 2019, so she underwent a hysteroscopic directed endometrial biopsy, which showed disordered proliferative endometrium. Looking at her age, looking at her reproductive requirements, sexual requirements, she was obviously counseled first for a hysterectomy, but the patient was afraid of surgery, so she opted for conservative line of management, so LNG IUS was inserted. She underwent 2 subsequent follow-ups, 6-monthly follow-ups with our unit. Everything looked good. There was no growth in the myoma. And then COVID happened. COVID happened and all the hospitals were closed for almost a year and a half. And we had to deal with all COVID cases. So all cold cases were put on the back burner. So we lost this patient to follow-up. She showed up in 2021 with history of expulsion of Mirena IUS. When we did an ultrasound, the myoma had grown irregularly and it was not looking very good. So we did an MRI where we got a potential diagnosis of sarcoma. Our ORs were still not open in this part of the world. So she was advised to go to India to go and get operated for a total abdominal hysterectomy with bilateral salpingo-oophorectomy. Patient went to her religious leader for advice, and the religious leader said, no, get it done through laparoscopy. Now there are recent advances. So she was posted for a laparoscopy by another surgeon. He went in and he put a uterine myoma screw directly into the sarcoma, and it started oozing out caseating necrotic material. The surgeon panicked and converted the surgery to laparotomy with the help of an oncosurgeon who was operating in the next OR. And they did a TH, BSO, omentectomy, lymph node dissection, the whole 9 yards, closed her back again with a midline laparotomy incision. And after 2 secondary debulkings and 18 chemos and radiations, we lost her after 1.5 years. So sarcoma, lesson learned, is that sarcoma, although the incidence is less than 1%, it is although the incidence is less than 1%, that means each one of us will encounter a case of sarcoma at least once in our clinical journey. Uterine sarcomas are infrequent. They are compared to leiomyomas. However, distinguishing between the two can be quite challenging. Another lesson that we learned is that the first surgery has to be the best surgery for a benign or a malignant leiomyoma. The clinical signs of uterine sarcomas and leiomyomas are analogous and characterized by increase in uterine size, abdominal pain, and abnormal uterine bleeding. Imaging is essential for distinguishing between these diagnoses, as benign leiomyomas can be treated with conservative interventions like uterine artery embolization, as already discussed, or limited surgical resection. In contrast, malignant sarcomas have very poor prognosis, and early complete surgical removal is the optimal treatment to minimize the future morbidity and mortality. We've had some brilliant speakers who have spoken about the role of imaging, but before we get there, risk factors for leiomyoma, as you all know, is very common among Afro-Caribbean women. We see it in Africa, very, very common amongst African women, especially of Afro-Caribbean origin. Genetically, although rare, but hereditary leiomyomatosis, which is a autosomal dominant disorder, can be associated with renal cell carcinoma and multiple fibroids. Diets play an important role. And of course, gynecological history, as mentioned before, with multiparity, hormonal replacement therapy, and OCP use can cause leiomyomas. This is an excellent article that we have incorporated into our clinical practice, where we do differentiate every single leiomyoma, be it in women with reproductive age group or post-reproductive age group, menopausal age group. We call it the BETTER check, which is the BETTER check. Before we go to explain you about the BETTER check, I just need to know, to inform you, the imaging studies is the only way to make a clear-cut preoperative diagnosis, because the final diagnosis of sarcoma is on the histopathological reports that come only once you send it to the lab for histopathology. The only way to arrive at a preoperative diagnosis of sarcomas is from benign conditions of leiomyoma is through imaging studies. As you've seen, Dr. Sonal Panchal Madam has demonstrated how amazing ultrasound and CT are. However, according to the European Union recommendations for radiology, ultrasound and CT lack the necessary soft tissue discrimination to differentiate between uterine leiomyomas and sarcomas for diagnostic purposes. The characteristic of metastatic spread, however, can be observed very easily on an ultrasound and CT, so can be used to facilitate the differentiation between benign and malignant lesions. However, these features may not always be present or captured during the initial evaluation. MRI is the gold standard for diagnosis of sarcoma. Metastatic diseases can be effectively diagnosed using ultrasound and CT imaging, as mentioned earlier, but upon the affected sites. And also you can see ascites, liver, lung, bone mets, and peritoneal deposits on CT. The more sensitive a test, the less likely an individual with a negative test will have the disease, and thus greater is the negative predictability value. The greater the negative predictability value, the more sensitive a test. And MRI is a superior imaging modality for differentiating leiomyomas from uterine sarcomas, owing to its capacity to evaluate tissue signal intensity characterized by typical fibroid appearance in a world homogeneous low T2 weighted signal intensity lesion, which possesses a remarkable high negative predictability value for benign fibroids. This is what we use in our setups to after fibroid mapping is done, to actually look at the malignant potential of that particular fibroid, where we see the sequence in T2 plane, which covers the axial, sagittal, and coronal planes. And here we use this rationale to check the anatomy and characterization of the fibroid. The T1 plane is an axial plane, which is used usually for the lymph node assessments and to identify if there is any fatty degeneration or hemorrhagic degeneration within the fibroid. Again, it can also be used T2 lesions can be used to assess the upper abdominal viscera and the lymph nodes, while we have diffusion weighted imaging, which helps to characterize atypical leiomyomas and helpful in diagnosis of sarcomas. And you have the apparent diffusion coefficient, which is also used to characterize sarcomas from a leiomyoma. Most of these MRIs have to be with a contrast where we use a gadolinium contrast. For gadolinium contrast, you need to have a creatinine, normal creatinine clearance for this patient. So that is a prerequisite that is needed for an MRI with pelvis, and it is used to characterize leiomyomas or sarcomas. Now, what are the key features to identify uterine sarcomas through imaging? It's called the better check. Due to low prevalence of uterine sarcomas, few extensive investigations have assessed MRI characteristics in leiomyomas and uterine sarcomas, including leiomyosarcoma as well. Numerous small cohort studies have consistently emphasized certain characteristics that can facilitate the identification of the uterine sarcoma. And we use the acronym BETTER that will serve as a good mnemonic to characterize these sarcomas. So what are they? B stands for borders. An irregular or poorly defined border on an MRI is a significant suspicious feature occurring in about 100% of sarcomas, and in contrast, mere 3.8% incidence in atypical leiomyomas. You have E, which is enhancement. Here we use the gadolinium dye, where the use of intravenous contrast medium enhances the diagnostic accuracy of uterine sarcomas. As you can see over here in slide B, which is shown with asterisks, uterine sarcomas originating from the myometrium generally exhibit a heterogeneous enhancement characterized by irregular lesions and frequently central, and that show a lack of contrast enhancement, and decreased enhancement is seen due to necrosis. Then we have the T, the first T, which is the T1 weighted image, which marks the presence of a hemorrhage. Subacute hemorrhage results in the formation of methemoglobin, which is picked up by the T1 weighted images, which exhibits elevated signal intensity, and it indicates hemorrhagic necrosis that is seen in up to 94% of uterine sarcomas, in contrast to up to 18% of leiomyomas, which are benign. A systemic review of nine studies indicated that the intralesion hemorrhage is associated with a 7 to 8-fold increase in leiosarcomas as compared to benign lesion. And the occurrence of hemorrhage within the uterine mass in the absence of clinical features indicative of red degeneration of fibroid strongly suggests the presence of a sarcoma. Then we come to the second T, which is the T2, which is much more important than T1. Low T2 signal intensity dark regions may result from flow voids or the presence of intralesional hemosiderin. And it has been demonstrated by Lachman et al. That it has a sensitivity of 84% and a specificity of 86% in feature of diagnosis of a leiomyosarcoma. The E comes with endometrial involvement. This is associated with adenosarcomas, which originate from the endometrial lesion and grow into the myometrium. Adenosarcomas exhibit a significant tendency for endometrial involvement. The aggressive characteristic of leiomyosarcoma indicate that despite its origin in the endometrium, it may also affect the endometrium in approximately 50% of the instances, as happened in the case that I presented just now, leading to altercations or abnormalities in the endometrial stripe. Assessment of the contour of the lesion in relation to the endometrium as well as serosal surface is crucial, as explained earlier, in cases suspected of leiomyosarcoma. R stands for restricted diffusion. High diffusion weighted imaging or restricted diffusion of the dye is seen in leiomyosarcomas. And that's how this particular chart is extremely important, where every single degenerative changes in a typical leiomyoma or a hyaline or cystic degeneration, red degeneration, lipoleoma or cellular leioma shows clearly that the borders are well defined in a benign lesion, whereas they are lobulated and irregular in a malignant lesion. Enhancement is heterogeneous as compared to the benign lesions. In T1 and T2 imaging is low with high sensitivity index in areas of hemorrhage, and intermediate or heterogeneous picture on T2 weighted images. Endometrial thickening Direct involvement is there, either irregular or thickened, and restricted diffusion is only seen in cellular leiomyomas or in sarcomas. So if any of these characteristics are positive, even one, and if there is a suspicion, then it is advisable by Figo guidelines as well to post this patient for a laparotomy and not a laparoscopy in order to avoid any laparoscopy-induced spillage of sarcomatous cells into the peritoneal cavity, upstaging the cancer from maybe stage 1 to late stage 2 or stage 3, or sometimes even a difficult peritoneous spread of the lesions as well. This slide just clearly indicates the Figo's recent updating of sarcomas. And as you can see, they have divided it into leiomyosarcomas or endometrial stromal sarcomas and adenosarcomas that originate from the endometrial cavity. And it is extremely important that when there is a imaging diagnosis features suggestive of a sarcoma, laparoscopy is out the door. You need to do an MRI to see if there is any extension of spread, if there is any hematogenous or lymph node involvement, if there is any other organ involvement, to stage it properly and post the patient, because you will only get one chance at surgery for such patients as demonstrated in the previous case that I presented. So it's extremely important that the right choice of surgery be made, the right option of surgery be implemented, because you just get one chance at enucleating a sarcoma. After that, it's if you have failed at doing it, then you've lost your patient. So in conclusion, despite the rarity of uterine sarcomas, it is essential to maintain a high index of suspicion during pre-operative imaging to facilitate prompt referral for suitable surgery planning. MRI is the optimal modality for evaluating uterine sarcomas, while CT can be utilized for assessing distant metastasis. Atypical leiomyomas have degenerated, are cellular, metastasizing, or intravascular, all possess at least one characteristic that can resemble the diagnosis of leiomyosarcoma on MRI. Nevertheless, integrated MRI imaging findings with clinical context is absolutely beneficial. And last but not the least, recognizing critical MRI imaging characteristics, including irregular borders, heterogeneous enhancement with central hypointensity, hyperintense T1, T2 dark regions, and signal voids, and endometrial invasion, restricted diffusion, collectively enhances the pre-operative suspicion for sarcoma, thereby augmenting sensitivity, specificity, and accuracy. I thank you all for a patient listening, and I shall stop my share. Thank you.
Yes, Shanta.
Thank you so much, ma'am. This was a wonderful talk. Dr. Shanta, will you like to conclude the session? Durge, madam? Yes. Madam, please unmute yourself.
Kalyan has done wonderful job. He has already answered all the queries in the chat box.
Yes. I was about to ask you, ma'am, because we are just jamming with the time. Do we take the questions, or we are going to answer on the chat box?
Quick. I think only one or two questions remaining. Kalyan has already answered. You take it quickly. Yeah.
Shanta, ma'am?
Start saying.
See, why it is Dr. Amla Kopkar has excellently described to differentiating the fibroids from the sarcoma, and why it is so important to differentiate the sarcoma and fibroids, because it modulates the our surgical methods. And if we suspect the sarcoma, then we have to go for the laparotomy and not for the laparoscopy. And one more thing, she has nicely told that the optimal modality for the diagnosis of fibroids and sarcoma is the MRI. That is the more superior, and gadolinium contrast MRI is. And this better check, what she has told about the better check in very detail, so everyone can go through it, and that is the very good mnemonic for the diagnosing fibroids from sarcoma. So thank you, Dr. Amla Kopkar. You have described it very well, and we are really benefiting from your description. Thank you.
Thank you.
Thank you all.
Thank you. Thank you.
Thank you so much, Dr. Shanta. Yeah.
Take the question.
Can we take few questions? Yes.
Yes.
So we'll start from Dr. Lakshmi, ma'am. I think we have 1-2 questions for each speaker. Lakshmi, ma'am, drug of choice for infertility patients have been asked, and ulipristal acetate regime to be repeated, please.
Ulipristal, I have mentioned, you can start 5 milligram tablet on day 5 of the cycle. Give it continuously for 3 months. Wait for the her cycles. Give break of 2 menstrual cycles before you start another 3-month course. Maximum you can give this intermittent therapy for 4 what I should say cycles. 3-month course for 4 times. But you have to do LFT at the start of the treatment, and you have to go on repeating LFT, and the moment you see elevated liver enzymes, you have to stop the treatment. For fibroid, for those patients who want to have fertility, again you can have ulipristal acetate. Then if she is for IVF, we do give GnRH agonist. So there are various options, but as I emphasize that it has to be individualized. What are her needs? What are her fertility plans in near future, or she wishes to conceive after 1 year? Accordingly, we tailor her medical treatment.
Okay, thank you so much, ma'am. Dr. Kalyan, sir, all the questions almost you have answered, but yes, there was
I'm
one interesting
interested
thing
in
about the
asking-
nanobots.
Yeah, nanobots are the specific target cells which are going to act on the disease cells, and they are going to leave the normal healthy tissues. So it's more of a genetic engineering. It is coming up in next 5 years. It will be helpful for cancer cells as well as in fibroids. It is going to be helpful. The question which many times somebody is asking about the how to take incision on the posterior wall myoma. In cases of laparoscopy, we have to use a manipulator, or you can take a myoma screw, apply anteriorly, and then take an incision posteriorly. In cases of open surgery, though I'm not doing since last 10 years, we have to apply these bony clamps which are available anteriorly and posteriorly, and then lift the uterus and then take incision posteriorly. Why am I worried about the posterior incision? It has been taught to us that you should not take posterior incision. But whenever the fibroid is completely on the posterior wall, you have to take a posterior incision, and don't open the cavity and take incision from anterior wall, because it is going to be difficult for suturing. Take incision, put a good omental patch, and nowadays is Interseed, which is available in the market at around only 2,500 rupees. So apply this Interseed on the posterior wall so that you can prevent the adhesion formation. Do good meticulous suturing. Don't keep the debris inside. Don't keep these cautery burns carbon inside, because it is going to cause lot of infection and then adhesion formation. I try to put around 200 ml of normal saline at the end of the surgery inside the peritoneal cavity. I don't know it is going to help, how it is help, but it is help for decreasing the adhesion formation. But nowadays we have shifted to Interseed.
Thank you, sir. There was a question on how to prevent recurrence of fibroids after operative surgery. So,
I have covered
seedling-
that point, that those fibroids which are there in laparoscopy, the recurrence is slightly more, because there is no tactile sensation while you are operating by laparoscope. Your hand is around 20 centimeter away. But in open surgery, you have to palpate it nicely. In cases of laparoscopic surgery, the fibroid mapping is very important. There are good sonologists who will tell you exactly at what point there is a fibroid, what is the exact size of the fibroid. My presentation, the second slide was on that. What is the size of the fibroid, number of the fibroids, location of the fibroid? That is called mapping. So you have to send this patient to a good sonologist so that you know how many fibroids you are supposed to remove. And those which are seen has to be removed in laparoscopically. But so many times my sonologist tells me that there's a 2 centimeter fibroid on the posterior wall, but apparently it is not seen. But I take an incision because I'm sure about the fibroid mapping. So fibroid mapping is a skill you have to develop, some sonologist or develop yourself, so that you don't miss these smaller fibroids, because otherwise they will be seedling fibroids which will become big fibroids in next 2 to 3 years.
And a good consent, like for multiple fibroids, definitely we need to take consent that there can be feeble chances of recurrence always. So patient has to be explained follow-up.
Yeah,
Yes.
and we take consent for hysteroscopic, whether there can be 1 cell or 2-stage surgery can be done, or even conversion to laparotomy is very important.
There is
Thank
one
you so much,
question
sir.
for Amla
Thank
as
you,
well. I can say.
Thank you.
Yes,
Thank you so much.
yes. Dr. Amla, there's a question for you. That was the role of LDH in differentiating
Parikshit sir,
sarcomas
namaskar.
and fibroids.
Sorry, LDH as in lactate dehydrogenase?
Yes,
No.
yes.
Yes.
I'm not aware. I mean, we don't use it, but definitely once we do the fibroid mapping, irrespective of the reproductive age of the patient, we do an MRI because of how this case was handled and how we had to lose this patient. So we do a fibroid mapping, and if we see even smallest degenerative changes on ultrasound, immediately we post the patient for an MRI pelvis with contrast so that we exactly get to know what we are looking at. And then we plan. If there are no signs of degeneration seen, then we go ahead with the laparoscopy. But otherwise, we open the patient and feel the uterus and take it out in the good old-fashioned way.
Yes, which is always promisable. Thank you so much, ma'am.
Wonderful.
Thank you so much, all the speakers and all the chairpersons for giving this wonderful session. Not taking any more time. Thank you so much for the opportunity, Lakshmi ma'am. Moving ahead, and I hand over it to Dr. Nagina ma'am
Thank
for
you, Dikshit
session
ma'am.
3.
Good evening to everyone. And now we are running towards our third session, that is fibroids in special situations. And there will be 3 topics, that is fibroids in infertility, fibroids in pregnancy, and fibroids in 40 plus age. And for that, chairing the session, we are having 3 dignitaries, that is Sandhya Pajai madam, Rajesh Singh Pardeshi sir, and Bharti Maheshwari madam. Actually, I can't see Pardeshi sir and Maheshwari madam. So let me introduce a very special chairperson of the eve, that is Pazai madam. She is also a great teacher. She has taught us at Yavatmal GMC. Most welcome, ma'am. And now presently, madam is professor at Datta Savangi. And is Pardeshi sir there?
Pardesi, I have not seen, but I think
Even ma'am Bharti madam is also not there. Then we can start with the first
no
session.
problem. Yes,
Yeah.
Doctor.
Now I request Pazai ma'am. Ma'am, are you there?
If you can't see,
Please do
just
introduce.
introduce briefly the speakers and start.
Yeah,
Nagina?
sure. Yeah, sure. The first talk already I told. Parikshit Tang sir will be going to take it. And definitely sir doesn't require any of the introduction. Sir is a great orator. He has done lots of orations and lots of publications to its credit. Sir, the house is for you.
Thank you, Dr. Nagina, and I must convey my thanks to Dr. Shrikhande for the kind invitation and for ICOG for having these very in-depth and really thought-provoking sessions which go to the root of our practice. So let me start sharing my screen and let's get on with the day. I've been asked to speak about fibroids and infertility. And Dr. Shrikhande told me, I think 3-4 days back, that will you take this topic? Is it okay for you? I said, yes, it's a very simple topic. I'll do it. It's so simple, easy. But as I started reading a little more about the nuances and enlightening myself with more recent literature, I must confess that I had 2 choices. Either keep it simple and tell everybody what I do in routine practice, or confuse everyone and leave people none the wiser. So I thought first let me confuse you all and then I'll give clarity at the end.
Great. Thank you, Parikshit. Thank you so much. I know I called you just 2 days back for this topic.
No, not a problem at all, ma'am. Thank you. So, I mean, we all know that fibroids are extremely common. I mean, there are hardly any women who don't have fibroids. And because it's such a routinely found pathology, we'll find it in pregnancy also, as Dr. Sarita Balerao is going to address us on this topic. Now, the thing is, if we find fibroids with pregnancy, then why is there a topic like fibroids and infertility? People should have gotten pregnant. But here, when we consider this overall picture about fibroids, reproductive outcomes, etc., we know that people become pregnant with fibroids. Yes, there's no doubt about it. And most of them have a good outcome, but some women will have fertility issues in the presence of a leiomyoma. Now, whether the fibroid is a causative factor, contributory factor, or it's a coincidental factor, that's the most important question that we have to answer today. Before we go any further, I want to caution everyone. First caution, when we are talking about infertility settings, medical management of fibroids is completely useless. It's a waste of time, effort, and money, because fibroid related medical therapies don't improve fertility outcomes, and they actually delay the real fertility treatment that this couple needs to undergo. So that's out of the window. Okay, if you want to give it for symptomatic measures, that's all right, no problem. But don't expect that the woman will become pregnant because of those medicines. First. The second thing is that all these newer modalities that we would be hearing about, such as radioembolization, magnetic imaging guided therapy, thermolysis, etc., they are all largely experimental, and they are not recommended in fertility seeking women. So if you want to effectively treat fibroids in a setting of infertility, you have to do a myomectomy. That's the simple first caution that I want to take with me as I go along. And the second is this very beautiful statements, a pair of statements made in the OBGYN survey, that the common practice of myomectomy for infertile women who have subserous or intramural fibroids without an intracavitary involvements is not only unjustified, but might be actually dangerous, because not only are you undertaking a myomectomy operation, which itself, like any surgery, has its own risks, but you're also risking future problems such as adhesions, and the woman who could have gotten pregnant with some other means will be left with no choice but to do IVF because of an additional peritoneal or tubal factor that you're adding. So one, myomectomy is the only thing that you can do to treat fibroids effectively in a setting of infertility. And two, think about whom you're offering and doing myomectomy for. So myomectomy in the infertile women, you have to answer these questions very critically before you subject someone to it. Is this fibroid causing the infertility? If these fibroids are there and they are important, should they be removed before starting any treatment? And will it change the reproductive outcome for this particular woman? We all know that there are lots of types of fibroids, right from, the various types that we learned in medical school. And now, of course, we all follow the Figo classification. And because there are such a large variety of fibroids, we also know that there are a large variety of treatments that one can do. So the indications really to treat the fibroid in an infertile woman is if she's symptomatic. And don't forget that infertility is also a symptom. If the symptoms are troublesome and they are due to the fibroids, the other decision-making point will be the size of the fibroid and the location. Probably we use location as our primary decision-making point when we are offering myomectomy or any surgical intervention. So it's very clear that, if it's intracavitary or submucous or distorting the cavity in some way, then you'll operate. If it's subserous pedunculated, you can conserve. The controversy is really in terms of the mural, and for the large subserous fibroids or large mural fibroids, the question is, what do you want to do? So let's come to the intracavitaries. And here I want to illustrate this example with this video. This is, of course, a case I operated on for the sake of heavy menstrual bleeding. But we identified a 5 centimeter intracavitary fibroid. It was a Lasmar 6. That means it's a high complexity hysteroscopy myomectomy that we are undertaking. And naturally, if you're going to undertake this kind of a procedure, you're going to tell the woman that I'm not sure whether I'll be able to do this all today or not. Might have to get you back into the operation theater again. The cavity was examined, and this is the primary thing that one must do to ensure that the rest of it is normal, ostia seen, your landmarks are where you expect them to be. Identify where this fibroid is arising from, but please never ever detach it from there, because if you detach it from there by some chance, you're going to be in trouble. For the size that this represents, the best choice for me is a bipolar cautery with loop in saline distension. Many newer modalities are available. Older ones are, of course, the unipolar. So if you're going to tackle an anterior wall fibroid, you're going below and behind, and then start taking large chips. Don't waste time or distension medium in trying to remove these chips. They will automatically move out of the way if your distension is adequate, and they'll remain away from your field. Keep going until a point comes where you can not identify the tissue that you're cutting. And at that point, please stop. Then you have to take a short break, clear out the chips, and then come back in again. So keep going, and occasionally the direction in which you're cutting will have to be reversed. Now, be very careful when you're doing this. This should really be in experienced hands, because there's always a chance that if you don't know how far deep in to go, you might actually damage the wall of the uterus. And that is something which can lead to perforation, bowel injury with a thermal source, etc. So that's the point of caution that one has to exercise. So with this kind of a technique, you can usually in a fairly short time complete the myomectomy procedure. And most important thing in this situation is, now we have taken the camera out, remove it by chips, remove the chips by ohm forceps, introduce the resectoscope again, and you'll usually find a small stump or some small leftover stub of tissue over there. So remove that too and ensure that you've done a complete job. Now, this size of a fibroid is naturally going to leave a bit of a rent in the endometrium and in the myometrium as well if you've gone very deep. But fortunately, the healing is good and the cavity regenerates. This woman will be able to have a good triple layer appearance after a couple of months. See that you've got adequate hemostasis, and that's about it. So it's a fairly easy procedure. Blood loss is quite limited if you remain in the right plane and don't dig too much into the myometrium. Saline deficit was under control, and we kept an intracavitary balloon for 5 days. She was fine. The histopath was also normal, no pain, bleeding, etc. Now, the thing is that generally when we do this, there are many options and concerns regarding the adhesion formation, and some new methods of preventing intrauterine adhesions, such as placing a barrier, a physical barrier, have been talked about. Now, coming to the other extreme, we know that these kind of fibroids are not going to affect the reproductive outcome at all. So most of the times they are incidental findings. I must admit that these are very, very old videos when, it was common to do a hysterolaparoscopy as a part of the workup for infertility. Nowadays, nobody is ever going to do that. And I don't have any modern videos showing these kind of fibroids, unfortunately or fortunately. But these are the ones that definitely to leave well alone. But what about these? These would be characterized as a mural fibroid, right? It's not an intracavitary fibroid. It's not a subserous. It's large intramural. If you see specimens like this in someone who's seeking infertility, what do? If you go by the textbook, they say, no, don't remove it because it's intramural. But Mural myomas can also affect reproductive outcomes by altering the blood flow, changing myometrial perfusion, increasing myometrial contractility, and altering the endometrial milieu, especially resulting in endometrial inflammation. Now, there is a further distinction that we are getting into. So this is the cavity. Here we see the intramural fibroid, and it is coming close to what is called the junctional zone. And the modern belief is that it is something around this junctional zone which influences endometrial behavior. And if the fibroid is impinging or disturbing the junctional zone, it might be a target for your surgical process. Plenty of studies and plenty of flaws in the studies also, because most of them are low quality observational data. Different modalities are used to evaluate the cavity. The impact of the mural and submucous components are difficult to distinguish. You may have a large mural fibroid, but then should you treat it just as mural or should you take it as a large mural? Of course, there are lack of controls, and usually we underestimate the impact of the fibroid. So SOGC, that's the Canadian Society 2018, not only recommends that we should consider a removal of these large mural fibroids, but they also go on to say that there might be some improvement in the clinical pregnancy rates. Of course, the improvement will be nowhere close to what we see with submucous or cavity distorting fibroids, but there is a benefit which will be there. And immediately there is also enough data to tell us that, well, it might not really be of that much use, and we'll have to remove lots and lots of fibroids before we really see any benefits in terms of numbers. Now, coming to the clarity. If I find fibroids in a couple who's seeking infertility, what do? I acknowledge that the fibroids may be asymptomatic and can be left alone for the time being. But I offer a myomectomy whenever the fibroids are large, they distort the endometrial cavity, or they are very, very large. I mean, 10 centimeter subserous is going to be a problem in the pregnancy also. And I make it a point to evaluate the uterine cavity after myomectomy. So this is what my real one slide practice takeaway is. So fibroids are always going to be there, all sorts of shapes and sizes. This is just a collage of my collection. And we have to be very discerning in terms of whom a surgical intervention is being offered to. Thank you all very much for your kind attention.
I was literally mesmerized with the video, sir. It was an excellent video. Thank you so much for that video. The checking was very clear. Yeah.
Dr. Sandhya Pazai is very much here.
Yeah. Pazai ma'am, are you there?
Yes.
Yeah, please, ma'am, please conclude the session. And after that, I'll take one question that is for the answer.
I am audible to you?
Yeah,
Yes,
ma'am.
yes.
Sir, it was a very informative lecture on fibroids and infertility. You have also given us information about the hysteroscopy and myomectomy procedures and how to take decisions regarding the fibroids in infertility for operative procedures. Thank you so much, sir, for your information in the lecture. Thank you, sir.
Thank you, ma'am.
Yeah, thank you so much, Pazai ma'am. Sir, the question is, what to be done for broad ligament fibroids of 4 to 5 centimeter in infertile patients?
Yeah, should be left alone.
He has already answered.
Already,
chat
he has
box. I
already
like
told.
that.
Yeah, exactly. So thank you so much for the session. That was very clear, crisp, and mesmerizing. Thank you.
Thank you, Parikshit. Thank you so much. You did full justice to the topic in 2 days' time. You prepared from confusion to clarity.
Exactly. Now I again request Pazai ma'am kindly introduce Sarita Bhalerao ma'am. Pazai ma'am.
Hello. It's my great privilege to introduce Sarita Bhalerao madam. She is a MD, DNB, FRCOG, consultant, obstetrician and gynecologist, Secretary, Indian College of Obstetricians and Gynecologists, immediate past chair, AICC RCOG West Zone, President, Mumbai OBGYN Society in 21-22, past President, AMVI Branch, Mumbai, past Chapter Secretary, Indian Menopause Society. I request you, Madam, to start with your presentation.
Thank you very much, Dr. Sandhya, for that kind introduction. And I'd like to start by thanking and congratulating Dr. Lakshmi for this fantastic program. I've been listening right from the beginning, and it's really been very, very informative and very interesting. So my topic for today, taking off from what Parikshit spoke on, is fibroids in pregnancy. And, fibroids in pregnancy are common. Almost now 10% of pregnancies present with fibroids in pregnancy. As women are delaying childbearing and becoming older, the incidence of fibroids in pregnancy is increasing. And what I'm going to discuss in this review, talk is what is the effect of pregnancy on fibroids? What is the effect of fibroids on pregnancy? Should you or should you not do a myomectomy with a cesarean section? And some rare situations like myomectomy scar pregnancy. So the first thing is that what does pregnancy do to a fibroid? Interestingly, almost 70% of fibroids will not demonstrate any significant change in volume. So, but up to 30% of them may grow. And growth is mostly in the first trimester, especially in the first 10 weeks. And this is because of the high estrogen levels. How much will they increase? The increase in volume may be 15% to 25% of the initial volume. So say if depending on if a fibroid is 10 centimeters, it can go to 12.5 centimeters. Now, what's also interesting is that smaller fibroids tend to grow, but larger fibroids tend to remain unchanged, or some of them may even decrease in size. All of them tend to decrease in size in the third trimester and in the postpartum. And unfortunately, the ultrasound ability to pick up fibroids is not as good in pregnancy because of the changes of the pregnancy and the enlargement of the uterus. So, therefore, the first trimester is very important, and we should note down any fibroids that are picked up early in the first trimester. Now, what if a patient with fibroids in pregnancy presents with severe abdominal pain? So three things should come to your mind. Is it red degeneration, which is the most common? If not, is it torsion of a pedunculated subserous fibroid, or is it impaction of the fibroid? Now, I'm going to discuss first fibroid torsion during pregnancy. And this is an uncommon complication, but there are case reports where fibroids have twisted during pregnancy. It presents with severe abdominal pain, nausea, vomiting, abdominal signs, acute abdomen. And these authors did this very nice case report where they said that myomectomy is a feasible procedure if performed in pregnancy. Candidates need to be chosen carefully because only those with symptomatic myomas, since abdominal surgery during pregnancy can be associated with an increased risk for the development of preterm labor and delivery. So if patient comes, the first thing is to try to stabilize the patient with analgesics, maybe antibiotics, IV fluids, etc. Wait for 24-48 hours. And then if patient is still not settling, and there is fibroid torsion, then the option is to go for a myomectomy, either open or either laparoscopic. And both these are indicated when symptoms persist despite pharmacological therapy. Then comes the question of red degeneration, and I think Dr. Sonal spoke about this difficult diagnosis in pregnancy. But what happens is patients come with severe acute pain, and this is because the fibroid grows, the tissue outgrows its blood supply, and you know that whenever there is anoxia or in the body, there is severe pain. So anoxia, necrosis, and infarction causes severe pain, or it is because kinking of the blood supply to the uterus to the fibroid as the fibroid enlarges causes ischemia and necrosis. This cellular damage leads to prostaglandin release, and bed rest, hydration, and analgesics in these cases is the only treatment. But we have to be very careful about the use of painkillers in pregnancy, especially non-steroidal anti-inflammatory drugs, because these in the third trimester can lead to premature ductal closure in the fetus, oligohydramnios, and pulmonary hypertension. So I think the safest painkiller to give is paracetamol. And then if not, one can move to the opioid group like tramadol, etc. But giving NSAIDs for a prolonged time can be very risky. And this is an MRI picture to show you the large fibroid plus the fetus. So in case of doubt, sonography, of course, is first line. And MRI can also be done very safely to identify the fibroid. Now, what about the effect of the fibroids on the pregnancy? Again, up to 30% of women may develop complications. These are all high-risk pregnancies. So whenever there are fibroids in pregnancies, we must in the first booking visit put it down as a high-risk pregnancy. Very important to note and to map the fibroids at booking. How many fibroids there are? Are they intramural? Are they subserous? Where are the fibroids? Are they close to the placenta, away from the placenta? So the size is important and the position of the fibroid also has to be noted very carefully right in the beginning. So fibroids can cause miscarriage. They can cause early pregnancy bleeding. Why it happens, we don't really know, but we have postulates that it is because of increased uterine irritability and contractions, or there is compromised blood supply to the fetus and placenta. Maybe there is also a factor of mechanical compression. Remember, the risk is more with multiple fibroids, more with intramural and submucous fibroids. And this takes me back to Parikshit's talk where he said the question is, should you remove the fibroids or not remove the fibroids? And thinking about it, when you have large fibroids, of course, if they're submucous, you need to remove them. If they are large fibroids, multiple fibroids, intramural fibroids, and patient comes in the interpregnancy interval, then one can think of removing them before they embark on a pregnancy. Again, if the placenta is close to the fibroid, then there is a higher chance of bleeding. Women with fibroids are twice as likely to have preterm labor than those without fibroids. And here again, multiple fibroids and fibroids contacting with the placenta appear to be risk factors for preterm labor. We need to watch them carefully. What about placental abruption and placenta previa? There is a threefold increased risk. Here, submucous fibroids, fibroids which are behind the placenta, retroplacental fibroids, and large fibroids are more likely to lead to these complications. And this occurs because there is alteration in the blood flow, leading to decidual necrosis in the placental tissue overlying the myoma, and therefore they get abruption, antepartum hemorrhage. Even presence of fibroids is associated with a twofold increased risk of lower segment implantation or placenta previa. It has been shown that women with fibroids are at a slightly increased risk of delivering a growth-restricted fetus. Even preeclampsia is more common due to defective vascularization. And large fibroids can compress and distort the intrauterine cavity, leading to fetal deformities. Also, large fibroids, if they're submucous, can cause dolichocephaly, torticollis, and limb reduction defects in the fetus. So definitely submucous fibroids are better removed before a woman conceives. I think we all are aware that malpresentations are more with fibroids and those in the lower uterine segment. Labor dystocia is also a problem. Caesarean chances are higher. Large fibroids, multiple fibroids, and fibroids in the lower segment are especially dangerous. And are large fibroids a contraindication to labor? No, you can try for a normal delivery, but remember that the risk of cesarean is increased. The risk of postpartum hemorrhage is higher, and these should be high-risk pregnancies done in tertiary centers. So third stage complications, fibroids distort the uterine cavity and interfere with myometrial contractions, leading to uterine atony and postpartum hemorrhage. There's an increased risk of puerperal hysterectomy and also an increased risk of retained placenta. What about uterine rupture after myomectomy? Remember that whether you do abdominal or you do laparoscopic myomectomy, the risk of rupture is rare. and the risk is 0.5 to 1%. But what we must remember is that 80% of the ruptures occur between 28 and 36 weeks, which is antenatally before the onset of labor. So rupture is more likely before the onset of labor and less likely in labor. This is because of stretching of the uterus. And of course, there's an increased chance of rupture with prolonged labor and oxytocin use. So these patients should not be subjected to these prolonged labors and oxytocin and things like that. Now, coming to the big debatable question, should you do cesarean myomectomy, yes or no? So it is a controversial area. It's very attractive, 2-in-1 surgery, yeah, same admission, same anesthesia. But remember that there is increased morbidity. Sometimes it may be necessary for fetal extraction or for suturing. And anterior wall fibroids may be particularly come in the way. Subserous or pedunculated myomas may be better can be removed. But if the patient has multiple myomas, deep intramural myomas, fundal or cornual myomas, they should not be removed because they are very vascular and you can land up in a lot of trouble. Having said that, the debate continues, and this is a very nice review article where they said cesarean myomectomy in the last 10 years, a true shift from contraindication to indication. And they say, these authors, that there is a clinically insignificant increase in operative time, hospital stay, and blood loss. And therefore, cesarean myomectomy, they say, should be preferred over cesarean section alone by experienced surgeons with appropriate hemostatic techniques and in tertiary care centers. And so I think that for us in practice, it's very important that we discuss this out with the patient. I think we have to tell the patient that it will be an increased operating time with increased hospital stay. There is a chance of increased blood loss, which may or may lead to a blood transfusion. These fibroids may itself reduce postpartum and may not require removal. And even if they need to be removed later, a laparoscopic surgery may suffice and they don't need a laparotomy. And this is one of my pictures. Just yesterday, I did a cesarean, and you can see the cesarean scar and you can see the fibroid there at the fundus. Very tempting to remove. I didn't remove it because I had not discussed it with the patient. But sometimes with an experienced surgeon with tranexamic acid 1 gram prior to surgery, you do the cesarean first. Unless the fibroid is obstructing baby delivery, the principles remain the same. Incision, enucleation, and suturing. And ideally, one should give an oxytocin drip for almost 24 hours post-surgery because of the risk of blood loss. I have personally had experiences with both things. I've removed a fibroid once and had bleeding, hemoglobin going down. Patient required blood transfusion. So I personally am not much in favor of it. But if it is a simple pedunculated fibroid and it is causing problem to the patient, you can always consider. I've also had a situation where the fibroid was obstructing delivery and suturing, and there was no other option but to remove the fibroid and then suture the uterus. So keep an open mind, discuss with the patient, and intra-op decision may be the best thing to do. The last thing I'm going to discuss is the pregnancy in a myomectomy scar, and these are rarer things which we are seeing now. And I was at the IAG conference where Dr. Paul spoke very beautifully on this myomectomy scar pregnancy, which is a rare condition in which the gestational sac implants within the scar. The patient presents in the first trimester with vaginal bleeding and pain. Sonography may pick up this. Sometimes MRI may be required for diagnosis. And this happens more when you do a myomectomy. The endometrium is breached, and the only option here is to do a surgical enucleation because methotrexate will not work. You have to enucleate and remove that pregnancy, which can be a very difficult surgery. But keep in mind, once in a while, we may see these things. So in conclusion, I'd like to say that fibroids in pregnancy, they have peaceful coexistence 70% of time, like many things in nature are peaceful. But once in a while, there is turbulence 30% of the time. And these are the difficult decisions to be made and the difficult things to manage. Thank you very much for personal patient hearing.
Ma'am, thank you so much. Pazai madam, are you there?
Yes, I am there.
Yeah, please, ma'am, do the conclude.
Madam, it was a very nice lecture on IFE, and you have told us about the effect of pregnancy on fibroid and effect of fibroid on the pregnancy. how to make a diagnosis and management of fibroid in pregnancy, and you also elaborated on knowledge about the various rare cases which you have seen. Thank you so much, madam, for your lecture.
Ma'am, there are two questions for you. The first one is post-menopausal fibroids, which are exactly not troubling the patient. Do you prefer removing, or you will be giving the medical treatment?
No. So see, I think my talk was on pregnancy and fibroid. But post-menopausal fibroids, if they've been there for a long time, they're small in size, you can leave them alone. You can watch them carefully. But if they are rapidly growing, or if they are anything like that, then of course one needs to remove them. Now remember, leiomyosarcoma usually doesn't occur in a fibroid which has been there for a long time. But if a new fibroid develops post-menopausal, suddenly the patient comes with a new fibroid and a large fibroid, then beware, it may be a leiomyosarcoma.
True, ma'am.
What is
Ma'am,
the second question?
can vasopressin be injected in cesarean myomectomy?
Now, these are very difficult things to do. Yes, you can. The principles do remain the same, but these are cesarean myomectomy is a very, very vascular situation, and we have to also be very careful of the risks of injecting vasopressin, because the vessels are open and suddenly it may go in and it may cause very serious damage and even cardiac arrest. So I personally am not much in favor of cesarean myomectomy, but there are many people who are doing it, and it
Exactly,
it's
ma'am.
controversial.
Exactly. Legal issues are a lot of them. Ma'am, the third question is techniques of myomectomy in C-section. Can you please elaborate? Is it done as a routine one, or is it some special technique is there?
No, so I said the principles are the same, but we give 1 gram tranexamic acid always. We give oxytocin for little more time, and we keep blood cross-matched and ready. Do it in a tertiary center and select your case very carefully. Discuss with the patient, select the case carefully, and then go ahead with it.
Exactly, ma'am. Thank you so much, ma'am. It was a very clear concept of fibroids in pregnancy. Thank you so much. Pazay, ma'am, I request you, please kindly introduce the next lecture speaker in 2 sentences, please.
Good evening, everyone. I am going to introduce Professor S.K. Zinat Ara Nasrin. Madam is gold medalist, and Professor S.K. Zikar Women's Medical College and Hospital, Dhaka.
Dhaka. She is from Bangladesh.
Yeah, she's from Bangladesh. So over to you, madam.
Nasrin, ma'am, kindly unmute yourself.
Zinat, unmute.
Thank you very much for your kind words. Can I share now?
Yes, please.
Sure.
Oh, so...
Meanwhile, ma'am, share our screen. One more question for
Sarita, you can answer in the chat box.
Yeah, even you can, ma'am, can do so.
Yeah, I will.
You know, ma'am. Yeah, please. Thank you so much.
Yeah, Zinat, please go ahead. Yeah.
Just a minute. Your picture is coming only. Last time I did it.
Yeah, I know.
Oh, I don't know what's happened now. Well, your picture is there only.
Gauri, allow multiple participants to share. Is there any problem at your end?
No, ma'am.
Is it okay? Can you see now?
No. Because in the trial run, we could see your PPT.
Yeah, I can remember.
Just stop it and reshare.
Okay. That's the thing I can start.
Yes.
Now I am sharing. But it's coming your picture only.
It's not.
Yeah, I could see this is. Oh my God. Okay, can you take the another laptop, please? Sorry.
You stop the screen share and reshare again. Stop the screen share.
Okay. I stopped it.
Now back to share.
Now I am pressing on the share. But it is your picture is only in the.
It's not coming. Maybe issues with
Let the other speaker stop their sharings of the slides, ma'am. Then maybe ma'am can do.
Yeah. Probably that's the thing. Entire screen. What happened? You see, to share audio is cancel. Okay, I am cancelled. I have cancelled. Okay, next.
If multiple windows are open, you can close those windows also.
When I'm sharing, you know, in the
No.
share screen, yours photo is coming only. Oh my God.
Oh, have you opened your PPT, ma'am?
Yeah, my PPT?
Yeah.
Yeah, I have opened that.
Then click on share screen. You will see the window of your PPT.
Okay. But where is the share? Yeah, give me the share screen.
Ryan, she was the first one to log in and check.
Yeah, I'm so sorry about this.
No, no.
I have another laptop. Just a
Yeah.
minute. I'm seeing only Lakshmi. You see? This is my one. Okay. Now I would like to share. Oh, what happens? No, it's coming here. Entire screen, देखो. She's the one here. Find it. Can you let me see here?
Meanwhile, how
You
is
can
fibroid
email me.
degeneration diagnosed?
Jinnat, you
and
can
treated?
email. I will share. Yeah.
Okay.
Yeah,
I
that
am putting my email ID in the chat box. I will share like I did for Farhana.
Yeah, sure.
Yeah. You also try? Huh?
Lakshmi, right?
S Lakshmi 2002 @yahoo.com. It has gone to Nagina. Yeah, I have shared. Bharat Kuresh.
गाड्या पण जात
Not received. Are there any questions in the chat box, Nagina, so that we can?
Yeah, I can take one. For
Yeah, you
Bhalerav
can
ma'am,
take questions.
how is fibroid degeneration diagnosed and treated during pregnancy, madam?
Sarita, are you with us?
Bhalerav ma'am, are you there?
Yeah, I'm very much here.
Yeah,
Yeah.
just.
Ma'am, how is fibroid degeneration diagnosed and treated during pregnancy?
So, red degeneration is the most common, and it's in a known patient with a fibroid. If she starts complaining of abdominal pain, maybe even getting fever, discomfort, then the commonest diagnosis is red degeneration. And you can, sonography is diagnostic, or you can do MRI if necessary. And basically, you have to give conservative treatment and they settle. If it is a torsion or something of a subpipe, they will not settle with that.
Thank you, ma'am. Thank you.
Jinnat, have you got my email ID?
And what conservative treatment is there, ma'am? For the red degeneration? Sarita ma'am, one again question popped up. What conservative treatment can you give? Sarita madam, are you there?
Yeah, is this question for me?
Yeah,
Yes,
ma'am, this is
yes,
for you.
you're, So,
What
a trial
conservative
of
treatment?
labor
I
with a
think it
history
is
of
regarding 9 months pregnancy they are asking.
Just tell her, I'll call back. So see, what I'm saying is, can we give a trial of labor in women with a history of myomectomy? You have to select your case very carefully. And the traditional teaching was that if the cavity was not opened, then a trial can be given. So I think that if it has been a subserous fibroid, for example, then it's not a problem. But if it's been a large fibroid, if it is submucous, if it is intramural, then it is risky to give a trial of labor. And if you do, you have to give a short trial with all facilities readily available.
Thank you so much, ma'am. Now I think Zinat madam is ready with her PPT. Thank you so much, ma'am.
Yeah, she's ready.
Yeah.
Okay, thank you so much. I'm so sorry.
No.
Well, thank you very much for the kind words. And of course, I would like to extend my gratitude and thanks to Lakshmi and all the entire team. I'm extremely sorry. So my topic of presentation today is actually fibroid at 40. Well, I don't have any disclosure. So it is very common that uterine fibroid are most common benign tumors in the reproductive age, and the prevalence is age dependent, commonly 80%, within 30 to 50% years of age. And in the OPD, if somebody is coming at the age of 40 with progressive menorrhagia and a mass or lower pressure in the lower abdomen, definitely diagnosed. Well, it could be AUV due to leiomyoma or fibroid, most probably. Actually, the aromatase in fibroid tissue allows endogenous production of estradiol, and fibroid itself, there's a stem cells that express endogenous estrogen and progesterone. That is the reason these are more common during the young group of women. But even we suspect this is a case of fibroid, we must have a very thorough evaluation. And that should start beginning from the meticulous history taking, pelvic examination, and of course, investigations. Well, the presentation is very common. I'm not going into details. Just the most importantly, the women are, if symptomatic, they complain of the heavy menstrual bleeding and their passage of clots, sometimes pressure, sometimes mass, and urinary problem. Even they come with the infertility. Evaluation, history taking is very important, I have already said, and the clinical examination. PV exam gives lots of information, no doubt. I mean, it's not that we can find that how big the fibroid is, what is the form, whether it is, mobile from side to side. It's not only that. We can see what's happening in the pouch of Douglas. What are the things in the adnexus? Always we have to keep our eyes open. Investigation, right, it's start from the blood, but most sensitive is imaging. And Dr. Sonal has given a beautiful talk on that. Ultrasound scan, that is the TVS is the most commonly performed, and we can diagnose lots of fibroid. Well, MRI and CT scan, we have heard from Sonal, it is reserved for the selective women. But if we suspect that someone is having, the fibroid could be malignant part, though my patient is only 40, is very unlikely, but nevertheless, only in that case, we can go for the MRI. And for submucous fibroid, definitely saline nutrition sonogram might help a lot. And what about the endometrial biopsy? Endometrial biopsy, well, the lady is only 40 to me, is very unlikely to have, very unlikely to have that she's having endometrial carcinoma. But if she has the risk factor, like she's obese, she is she had history of PCOS, and the ultrasonogram showed very thick endometrium. Even this age, there is a less chance of endometrial carcinoma, but there's a possibility of 1% chance of carcinoma. So in that case, we can go for the endometrial biopsy. Treatment, definitely we have heard since the beginning of the webinar. That is actually, it should be individualized. It will based upon the symptomatology of the patient and where is the fibroid, what is the size, what is the location, what is the age, this age is 40, she's actually 40 years old. What is her future fertility desire? And what are the available options is having with me? And what are the expertise or how experienced I am? Of course, if she's asymptomatic, we don't require any intervention except follow-up. But if she comes with the bleeding, heavy menstrual blood loss, then definitely we are going to give her medical treatment initially, hormone, antifibrinotics, NSAID, even Follis catheter, until the full evolution is done. And of course, then we can look for the conservative or definitely surgical intervention, depending upon the patient's condition. Medical treatment, yes, Dr. Lakshmi has beautifully described. We are almost, enlightened. But one thing is important, that even the medical treatment, we need to individualize. There are levonorgestrel intrauterine system, gonadotropin releasing hormone agonist, antagonist, selective progesterone receptor, oral contraceptive progestin, danazol, aromatase inhibitors, lots of them. But most commonly, LNG-IUS system we are using in 40 years old lady, if she doesn't want a baby, because this it will help her as a contraceptives, and it stabilizes the endometrium. Most very effective medical treatment. It reduces her blood loss and decreases the fibroid volume. Yes, there might be some irregular spotting, and if the fibroid is pressing the cavity, there's increased risk of device expulsion. Oral contraceptive pill, again, in this age, my patient is not willing for baby right now, and she has already completed her family, I can offer her OCP, but sometimes OCP will reduces the blood loss during administration, but it doesn't cure the fibroids. So we have to go for the other options. Selective progesterone receptor modulators, Dr. Lakshmi has nicely described, so I'm not going to discuss much more. What I'm doing, I would like to say that 2018 European Medicine Agency and UK have combinedly recommended that whenever we are starting ulipristal acetate, we have to go for the liver function testing. And in between the course, we have to do, at the end, we have to do the liver function testing. And if we can find that liver function, that is, ALT and AST are doubled than the normal level, we have to stop it. And if somebody has liver function dysfunction, we shouldn't use the ulipristal acetate or SPM for them. For my patient, she's 40, and if she wants a medical treatment, I would love to discuss with her about the agonist or antagonist, because both the medicines are very effective. They stop the menstrual cycle, they shrink the fibroids by competitively blocking the pituitary GnRH receptors. But for GnRH agonist, we can use it less than 6 months without add-back therapy. But if we want to use it longer, like 12 months, we have to give her add-back therapy. Because we all know that it produces menopausal symptoms, and add-back therapy reduces the night sweatings, vaginal dryness, and prevents the osteoporosis. But the GnRH antagonist, well, this is expensive, but it's a promising drug, and it's now slowly becoming the therapy of primary choice. If my patient is having her family is completed, I would love to offer her GnRH antagonist because it diminishes the fiber size and more when it's better than the GnRH agonists, and it has less side effects like hot flushes, bone loss, vaginal dryness. And Fearman et al. In his study, he showed that the granulix resulted in a considerable reduction in the volume of the fibroid by 25 to 30% within only 3 weeks. And since 2020, there are a lot of researches going on. Effectiveness of antagonist of our fibroid has been confirmed in many clinical trials and meta-analysis. And it can be administered as long as up to 24 months. And there are some interesting researches going on. What will be the effect of the elagolix on the outcome of the pregnancy? We'll listen for that. But as a whole, both groups can be used, but agonist probably mostly for preparation of surgery. On the other hand, antagonist can be used for the long-term therapy. So I will skip that one. Surgical intervention, yes, already we discussed, Dr. Kalyan has nicely described. But my patient is 40, if her family is completed, if she doesn't like to continue, she doesn't like to have the myoma probably I would offer her laparoscopic, hysteroscopy, robotic, which is available in my place, that one. But if large fibroid, definitely I think abdominal myomectomy reserved for the larger fibroids, because for endoscopic surgery it will be very challenging. And of course, again, abdominal myomectomy had a lot of complications. We know we have to discuss with that. Victor Bonney and he advocated earliest myomectomy, and myomectomy should be done to maintain and restore the physiological function. So if my patient at 40, she wants to have baby, probably we have heard from Parikshit. Dr. Parikshit has nicely described that myomectomy would be the choice. If it is submucous, removal hysteroscopically. And if it is, bigger laparoscopic myomectomy would be the best for her. But definitely, according to the Figo's classification, we have to have map the whole fibroid. How should we proceed for the myomectomy? And during myomectomy, I know vasopressin, bupivacaine, epinephrine, misoprostol, pericervical tourniquet, gelatin, all we need to give according to the patient's condition. Uterine fibers are also, we know that it is associated with the miscarriage and preterm birth. So I have to take the detailed history from my patient. If she is in that categories, probably we need to go for removal of the submucous fibroid, because in Sheffield, Lee et al. Has nicely showed in his study that there's a successful outcome following myomectomy in UK. And if women do not wish to preserve fertility, as well as the uterus, or she's not responding, no, I will give the options. If she doesn't like to she'd like to bear this bothersome bleeding, probably I will counsel her all the techniques, all the alternatives, risks, and then I would offer her the hysterectomy in the best possible, in the easiest way. Uterine artery embolization and HIFU, we have heard from Dr. Farnadian very nicely, so I am skipping the slide. Natural remedies. This is very interesting. When I was looking for the literature, the Chinese and the Japanese, they are dying to, cure fibroid by the natural remedies like acupuncture, exercise. Many literature have seen they are changing the dietary pattern and avoiding the hot meals, hot diet, and the managing the stress level. But unfortunately, these are not yet been evidence-based, so we can't actually comment. So I can summarize, my patient is 40, if she's asymptomatic, because I don't know, she's only 40. If she's asymptomatic, I know incidentally we have seen her that having fibroid, well, the clinical surveillance is the only thing. And if she's infertile and her uterine cavity is distorted by submucous fibroid, if it's seen by TVS, definitely myomectomy has to be offered depending upon the type of submucosa, either hysterectomy or laparoscopic. Symptomatic women who desire future fertility, medical treatment and myomectomy. And symptomatic women who do not desire future fertility but wish to preserve only uterus, then definitely you can go for the medical treatment, and if not, the myomectomy, and then the non-invasive surgery like uterine artery embolization and HIFU. In Bangladesh, we don't have HIFU, we have embolization. And finally, the possible way I would like to offer her hysterectomy if her family is complete and she can't bother some symptoms of heavy menstrual bleeding. So I'd like to conclude by saying that women having fibroid at 40 is very, very common. But evaluation is the key, because we never know this fibroid is benign only, because Amala has said a very interesting case history. So we have to look deep into the fibroid. Medical treatment is reasonably very effective, so which can spare surgery. Asymptomatic women will get the assurance, but medical treatment for those who are symptomatic, surgery or medical treatment. Finally, I would like to say that whatever the treatment option I will offer her, either medical treatment or surgery, invasive or non-invasive surgery, we have to have talked to the patient. We have to describe all the risks and benefits of that particular option. And finally, we have to come together into consensus, and we have to go for the shared decision. that will give us the best outcome.
Yeah.
Thank you very much for kind.
Nagina, I can see one question for Dr. Jinnat.
Yeah.
And before that, I can see comment from Dr. Maninder Ahuja that she has very good experience of elagolix in perimenopausal women. And Jinnat, question for you is cost effectiveness of mifepristone versus ulipristal, as he said, versus agonist and antagonist with special reference to side effects at 40 years of age.
Ma'am, unmute yourself. Zinat,
Unmute.
madam, unmute yourself.
Cost effectiveness of this different medical management and the side effects in reference to the perimenopausal age group.
Well, is this the question to me, Lakshmi?
Yes. Yes.
Well, that is a very interesting question. I think we have discussed that one. Cost effectiveness. Definitely we have to, the first thing, we have to honor the patient's desire. So whatever the cost, I have to discuss all the options, and it is in her pocket. She'll decide which will be best for her. But at the same time, I have to guide her because she doesn't know all the risks factors. So at the end of the day, if my patient at the age of 40 and she doesn't need a future fertility, I would offer her medical treatment for some time because she's 40. She has to go to menopause for 5 to 8 years later. But if she doesn't respond well and she's not very happy to carry on the expensive medicine like elagolix, relugolix, probably I would talk about the surgery because she doesn't, if she's happy with the surgery, I'd go for the hysterectomy if she's not that rich. But if she wants that I want a uterine artery embolization, probably I'd go for that. So it depends upon the patient's social condition, her attitude, her symptomatology, and her acceptance. And of course, the expertise, which is prevailing in my department. Thank you.
Thank you so much, ma'am. With this, I just want to say when life is sweet, say thank you and celebrate. And when life is bitter, just say thank you and grow. And fibroid is like so. And for this successful conference which we had today, definitely the backbone is Lakshmi madam, Lakshmi Shrikhande madam. I think she needs 3 rounds of applause.
Thank you.
3 cheers for ma'am. Yeah, you were great doing everything what you had done. And I'm very thankful to all the speakers, all the chairpersons, and all the techno team which we had supported us today. And all the participants, madam, whole time I had seen from 4 to now till they are 80 plus people. Yes. And up till 6:45, they were 120 members in flow without fail. So it is a great success for you. Congratulations and thank you so much for taking us into.
Thank you. Thank
Dr.
you.
Lakshmi, and congratulations for the great webinar.
Thank you, madam, for staying till the end. I can see Amla staying and Jinnat staying and so many senior faculty staying till the end. I can see Pushpa madam also. Maninder, unmute करो Maninder को.
It was really a very wonderful
Maninder जब से
masterclass,
comments कर
Lakshmi.
रही है. Maninder, now you can comment. गौरी, Maninder को unmute करो.
यस मैम कर दिया.
कहाँ कर दिया? मनिंदर मैडम आ जाओ, शॉर्ट में आपके कमेंट्स दे दो, देन वी विल से टाटा बाय बाय. नहीं, अनम्यूट नहीं हुई ना गौरी, को होस्ट बनाओ.
को होस्ट बना दिया है.
मनिंदर अनम्यूट करो. नहीं कर पा रही हैं. तुमने को होस्ट बनाया?
यस मैम.
पर वो तो बोल रही है कि उनको नहीं किया तुमने.
नहीं कर दिया है.
अच्छा, let me see.
आ गई आ गई आ गई.
I had to do.
तेरा दमदार आवाज आ गया, बोल दे.
Yeah, I think Lakshmi, that was a wonderful webinar. And initially I was thinking, yeah, fibroid mein kya hoga ba? But anyway, every speaker was good and we learned something. My main interest was, like I had written about the perimenopausal women. Because I had a couple of patients where she was almost menopausal, scanty menses, and she had symptoms of genitourinary syndrome. And accidentally diagnosed at that time with fibroid with 18 weeks of uterus. But no symptoms. Patient didn't have any symptoms. And she was advised surgery by all the gynecologists. That is the attitude we want to
because she was almost menopausal. Anyway, we could have given her other drugs, medications also. And there was no chance of recurring that big fibroid and no chance of sarcoma. That message has to be given, which Sarita had given very nicely, that if the sarcoma is there, that is there from the initial. And if the fibroid is there for a long time, that's not going to develop the sarcoma. So even if we have to do the post-menopausal surveillance, that is not earlier than 3 or 6 months. And I think even 0.1%, I went to the literature, just 0.1% chance of leiomyosarcoma is there. So that is, I think, Lakshmi, you give the very clear carry-home message that perimenopausal, as long as possible, we should be given. I have tried the ulipristal also in these patients, and they also responded well.
Yes,
And
that is the main indication for medical management, perimenopausal woman and towards menopausal woman.
Another,
Lesson to all of us.
Lakshmi, I tried alcoholics in the adolescent girl who had an endometrioma of about, I measured yesterday, 7 centimeters into 5 into 4 centimeters. And again, she's an unmarried girl of 20 years. And again, she was advised surgery. I did not good. I put her on that. 2 months have gone. She has no pain now. Minimum of pain is there. So we should be thinking that we can follow them. That they are not
For the
increasing in
adolescent
life.
girl, did you
Yeah.
administer her ADVEC therapy for the adolescent and alcoholics?
No, I just given them 2 months only. That I'll decide later on. That I'll decide later on, looking at her symptoms and her need. I have that thing in mind.
No,
But
the recommendation, they
I'm
don't
telling
say.
you that
No,
these patients are
Jinnat, I mentioned in my PPT that GnRH antagonist used for shortest possible period of time with minimum dose.
doesn't give.
So what
It
she is
doesn't
saying is
give
right, 150 milligram OD, you
Yeah.
can give for 2 months, 3 months, but maximum you can give is for 24 months. That is the FDA approval and DCGI approval. You
Exactly.
need not give it for 24 months. Give it for 2 months, 3 months. If symptoms are, you have achieved your objective, stop it. And if you are using it for short duration, you don't have to be ADVEC therapy also.
Yeah, short period, no need. But
No need.
adolescent girl,
Yes.
if we longer use,
In
we have to.
any hysterectomy, that 50 years is going to have side effects for that
Yeah,
woman.
because they are already towards
They will have the
osteoporosis.
local surgical effects also. And then again, the problem of sexuality will be there. And the problem of hypoestrogenism and hypoandrogenism. That is also going to be less level of androgens also. So we should always keep in mind. And wonderful
Yes.
presentation by everybody.
Thank you.
Sarita's
Thank
message
you,
that
Maninder,
the
for your.
pregnancy and fibroids can exist in a friendly way.
Thank you,
Thank you
Maninder,
so much,
for
madam.
giving your expert comments. And Nagina has already proposed formal vote of thanks from my side as a convener. A big thank you to all the 3 coordinators, all speakers, chairperson, and of course, dear audience, you all. See you all for our next masterclass. Till then, bye.
Good night, ma'am.
Bye-bye.
Good night, everyone.
Good night, everyone. Bye.